We see FMF angle, we do not see it very oftenly, but yes, this is a marker we see. Ductus venosus, assessment of aneuploidy and the heart also. Similarly, tricuspid regurgitation for heart and the aneuploidy also. So 5 aneuploidy markers we assess. 6 beautiful images. Now these images, whosoever is started learning NT scan or want to learn NT scan, these beautiful images has to be in your picture memory, and almost the anatomic evaluation will be over. The first, a butterfly appearance. When we put our probe on the head section, we see a beautiful butterfly. As soon as we see this butterfly, the brain and anomalies like holoprosencephaly, hydranencephaly are absolutely ruled out. We see a nice triangle at premaxillary triangle. So we see a palate and the nasal bones also in this section. A V section. This is a picture memory for NT scan also, for anomaly scan also. This is the confluence of pulmonary artery and aorta. This rules out major outflow tract abnormalities. Two vertical colorful strips. This indicates a good four-chamber view, and major abnormalities like hypoplastic heart syndrome are ruled out by this section only. Then we come to happy man sign. This is umbilical cord. It gives us two umbilical arteries and a beautiful railway track appearance, that is the spine. So we have seen so many organs in a beautiful appearance manners. So what are the rest of the organs which completes our anatomic evaluation? We see two upper limbs, two lower limbs, we see two kidneys and two orbits. These are the 8 organs. Our anatomic evaluation is over. 9 detectables. So this in detail will be taken by Dr. Priya. I will just enumerate them. What abnormalities we must detect on NT scan. That is acrania, holoprosencephaly, encephalocele, exomphalos, gastrocystis, megacystis, body stock anomaly, missing limbs, and iniencephaly. These 9 must be detected on NT scan. There is no excuse to it. This person. This person has revolutionized NT scan. Prior to Kipros, NT scan was done. But what this person has done is he has researched on particular criteria. So there is no question about it ki why we should do NT scan in this particular section only, why these criteria has to be met. One clear message for all of us is, if I wish to do aneuploidy screening, I have to take the section in this particular criteria only. If I am not taking in the same criteria, I cannot do aneuploidy risk assessment, because Kipros has not done a research in this random NT scan measurements. A clear message has to be gone to everybody. The NT scan image has to be like that for aneuploidy screening. Just you want to complete NT scan without aneuploidy screening, you can take in any way. This is a beautiful picture. Now I'll describe this picture in a short slide, that what are the criteria to be fulfilled for NT scan. First of all, tip of the nasal bone. This whole thing I call it as we call it as nasal bone complex. We see the skin, a double equal sign, that is overlying skin and the more echogenic nasal bone. A square shaped palate and a circular diencephalon. We come down, we should see good NT with two parallel lines. The fetus should be in a neutral position. There should be a liquor pocket between the chest and the chin. Gain should be down. Now, why gain should be down? If you acquire this image, the gain has to be down, because if the gain is up or the image is brighter, the edges are chalky. You don't know exactly where the caliper to be placed, and even a slight measurement mistake can change the values a lot. Now, where the caliper to be placed? These are the NT lines. The calipers has to be inner to inner, very clear. Yeah, whenever you submit images for NT accreditation, this inner to inner or overlaying of the caliper they see very specifically. Now, if there is a cord between, if there is a nuchal cord and we see NT on both sides, then We take on another side, we take another side, and we take a mean of both of the values. Now I come to some tips and tricks. The audience who want to learn anti-scan, these may be helpful. The audience who already know it, it may be a little entertaining factor for all of us. So what are the tips? The stick the pick trick, broom with zoom, power of pivoting, retake with cine, strength of sleeping probe, putting nose in beam, and troubleshooting. Let's go to them one by one. Stick the pick, a very beautiful concept. Anybody who want to learn anti-scan, just stick this picture on the wall next to it. You keep on seeing that I have to acquire the same image like this front image on down here. Your brain gets the coordination right to get this image. You get this habit initially. That is called as stick the pick trick. Very beautiful trick to learn anti-scan. Groom with zoom. This is very important. We have this big screen, and many a times we have seen images that it is totally zoomed out, not in a normal section, it is zoomed out, and people are trying to take anti image. So in this zoom out, it is so difficult to get all the criteria correct. What you do is you just zoom in or put a cut box there, and you see the landmark so clearly, and you can take the images, the anti scan image nicely. That is groom with zoom. So make it a habit that you adjust your anti-scan image with a zoom image. It's very important. Power of pivoting. Yes, this is a good concept. Whosoever want to learn anti-scan, see, this is the image we acquire. There are two complexes which are supposed to be in the image. One is nasal bone complex, one is the anti-IT complex. If you are learning initially, it is very difficult. The fetus slips off, एक complex आता है, दूसरा नहीं आता है. So you want to learn the pivoting with the probe. So what is it? First, we acquire any one of the complex, preferably the nasal bone complex. This is the parallel and the tip, and we keep the same complex continuously in the image without moving it. The probe has to be constant on that complex, and then we manipulate the probe slowly to acquire the second complex. That is the NTIT complex. That is called as power of pivoting. The experts who are trained into NT scan, this happens involuntarily, but who are learning the scan, who are trying to learn them, this can be a good way that you acquire one complex, hold the image there, and without moving that complex, try to acquire the another complex. Very important concept. Retake with cine. Yes, the persons who are learning the NT scan initially, a very good thing. What is the habit we learn initially is we go to NT image and stop and make a stop button or pause button, then only we'll get the image. We try again, we pause, and the image goes off. So it's a simple way. We take a cine loop. Our eyes, our brain knows that the image has gone behind. We pause, we take a cine loop slowly behind and take an image. Very good. Art of sleeping probe. Yes, very important. We are trained for the probe to go like this. For another scans like Doppler or anomaly scan, this skill may not be that important, but for NT scan, this skill is very important. All my senior other colleagues and experts will laugh at this slide, the art of sleeping probe. No, you need to acquire this to go deep into the tummy, this side, that side, to save the time and acquire the image quickly. Putting nose in the beam. This is important. Many times we start taking NT scan, we do not see nasal bone properly. So whenever the nasal bone is at an angle to the ultrasound probe, it may not shine correctly or you may not get the length properly. So it's a basic skill that the nasal bone, if I turn into the ultrasound uh, beam, the ultrasound, the nose nasal bone shines properly. See, have a look at here. I am turning the probe and the nasal bone shines very nicely. So it has to be perpendicular to the ultrasound probe to get the nasal bone complex very nicely. ट्रबल शूटिंग, दिस इज वेरी गुड. कुछ नहीं मिल रहा है, नो मैजिकल सेक्शन, कुछ तो उल्टा पुल्टा है. So many patients are sitting outside. How to acquire the skills of troubleshooting? A good concept called as abdo TVS adjustment. This will come over time. Abdominally we see image like this, कुछ नहीं मिल रहा है इस इमेज में, but gradually we come to know कि किस abdominal image के साथ अगर मैं TVS probe डालूं तो मुझे ऐसी image मिलेगी. So that is called as abdo TVS adjustment, and it has to be very quick before the fetus changes the position. Good skill. Ulta ka pulta skill, yes, very important. The fetus is lying upside down. We can't wait long for the fetus to turn. So we can just flip the fetus upside down and acquire the image, provided the FMF criteria are met. That is a very important point. Shirshasana, yes, we see so many times fetus lying like this. Buttocks are up, head is down, NT nahi mil sakta hai. Don't waste your time. This is the best and ideal position for ductus venosus. The angle of ductus is in your the ultrasound angle or the pulse wave Doppler angle. Just take it DV, beautiful DV image you will get. Last, totally awkward. कुछ नहीं मिल रहा है. Fetus आड़ा टेढ़ा लेटा हुआ है. What to do? These are very important. First, you can go to the other part to finish your scan. That is uterine. You see placenta. You see some anatomic structures. कुछ भी नहीं मिल रहा है. Then the quadruple funda of ultrasound. बैठो, पानी पियो, घूमो, खा के आओ. इसके अलावा आप कुछ नहीं कर सकते. Now I come to my last slide. That is the take-home message. The take-home message is not from me. The take-home message is directly from the fetus. Now, what fetus is trying to say in the clip? If you want to do NT scan, do it in this section or don't do it. He's angry. He's angry because after so many years of, so many years after Kipros has revolutionized NT, still these things has to be taught to everybody. We don't know why. The fetus is also angry because there are so clear-cut guidelines that NT has to be taken like this. Every day we have to teach like this. Our teachers are taking so many efforts, but still the NT is taken day in day out like that only. The reason we don't know. We have to develop a lot of patience, lot of dedication and passion for the profession. Then only each and every NT image has to be like this, approximately like this, to fulfill the FMF criteria. Thank you so much.
Thank you, sir, for very informative this presentation. Hello.
Yes, I'm there.
Thank you, sir. To everyone, please mute your mics. So the another topic is from Dr. Priya Deshpande, ma'am. She is a consultant, fetal medicine consultant in Motherhood Hospital, Apollo Hospital, and Hiranandani Hospital, Powai. She is a treasurer of AF Association of Fetal Medicine Consultant, Maharashtra. She is a West Zone Coordinator, Foxy Imaging Science Committee, and faculty at Fetal and Gynec Imaging. So over to you, ma'am, Priya, ma'am.
A very good morning, all. Can you see my slide?
Yes, ma'am.
Yes, yes.
Just a minute. Yeah. So, first of all, a very good morning to all the viewers, and really happy to see so many of you logged in on a Sunday morning. Now, my topic of discussion today is the first trimester anomaly scan, a window of opportunity. Now, Sachin has very well explained to us that how do we do an NT scan and the NT image and CRL image. But now I would really want to stress in another point that normally Usually we do an anomaly scan at 18 to 22 weeks, and it's been going on since decades. But now we know that with advances in technical skill and ultrasound technology, as well as our understanding in embryology, we can now assess the fetal anatomy to a greater detail right in the first trimester. Although the first trimester scan can really not replace a second trimester anomaly scan, but it can be of much use in assessing the anatomy from head to toe. So my tagline is, if you look, you will find. ISO guidelines. So we know these guidelines were published way back in 2013, and they give us a systematic approach towards screening the fetus from head to toe. And a list of 10 images needs to be documented in this fashion to complete our anatomical survey. Now, today, the scope of my talk is to understand this ISO protocol, and secondly, to go beyond ISO guidelines. So these two classic images have been explained very much in detail. And how do we assess the fetal anatomy? We see beyond these classic images in an axial scroll from head to rump. We see the axial sections of fetal head, brain, heart, thorax, the stomach, abdominal wall insertion of the umbilical cord. A lateral sweep shows us the upper and lower limbs in all three segments, and a slight oblique view shows us the orbits with lenses and the retronasal triangle. Now, to see the fetal spine, okay, so this is a live demonstration of a scan, and here we can see how we are scrolling from head to toe. We have seen the head, brain, the intact cranium, the fogs. So this is the heart beating and the stomach on the same side, which ascertains the normal situs. And then this is the abdominal wall insertion, the umbilical cord, the two extremities. Here we can see the fetal heart, the 4 chambers and 3 vessels on the color Doppler flow. To see the fetal spine, we have to wait for the fetus to jump and to turn in a prone position. We see the fetal spine in a longitudinal and coronal views. What we have to note is the normal vertebral alignment and integrity and intact overlying skin, and particular attention to the normal appearance of spine has to be done or given when BPD is less than 5th centile. We know the fetal kidneys are bean-shaped echogenic structures, and we can further delineate them by using color Doppler to visualize the renal arteries. So 3D, 4D is a new kid in the block. And of course, it's fascinating for the couple to see the fetus, and they can see it as though they feel that they are looking at the fetus in a live mode. And for us, as fetal medicine specialists, it is of importance to explain the abnormalities to the couple, in particular the defects which are associated with the surface anatomy, like for example, open neural tube defects, open abdominal wall defects or missing limbs, and so on. Now, this was a paper which was published by Singalaki Group and Professor Nicolaides Group in 2011. This showed that fortunately 5% of pregnancies are abnormal. And we've gone so far with screening for aneuploidies and downs, and especially with NIPT, but we must bear in mind that these anomalies or aneuploidies form only a small fraction of the spectrum, while the most neglected abnormalities in the first trimester are actually structural abnormalities, which actually form a major part of the spectrum, and fairly large contribution comes from the cardiac defects. And this paper showed that almost 50% of these structural defects could be identified in the first trimester. In India, we conducted a similar study, and this data was published, and the study group was around 12,000. And the same conclusion was the detection rate was around 55% in the first trimester. And grossly, all the anomalies were categorized into 3 groups: always detectable, sometimes detectable, and never detectable abnormalities. Now, with in due course of time, many of the abnormalities in the sometimes detectable group have now shifted to the always detectable group, thanks to research and studies in the field of fetal medicine. So this is a list of always detectable, which even Sachin has told you. And let's go through them one by one. Here we see the fetus. Of course, the head and brain doesn't look normal, and the cranium is absent. We can see a distorted shape of the fetal brain. It is almost elongated here, although the fetal profile and the neck and the cervical spine look okay. So this is a spotter for a cranium. Coming to the next case, Here we can see that the cranium is intact. However, the midline forks, which divides the brain into right and left hemispheres, is absent. It is discontinuous anteriorly, and there is fusion of thalamus.
Dr. Priya, I think you're muted. Can you please unmute yourself?
Yeah, am I audible?
Yes, yes.
Yeah. So should I repeat? Okay, I'll just continue. So in this clip, we can see that the cranium is intact in the anterior portion and there is discontinuity in the posterior end.
Dr. Priya,
And
you will
this,
have to go a little back. You'll have to start
okay.
after crania. Yeah.
Okay, sorry for that. Mhm. Okay, fine. So this is a picture where we can see the cranium is intact. However, the midline forks, which divides the brain into right and left hemispheres, is not seen continuous. And there is a discontinuity or a break, which shows a monoventricle, and the thalami are fused. So this is classic of a lobar holoprosencephaly. And we know there is a high association with aneuploidies, in particular trisomy 13 and 18. This is a case in which we can see the fetal cranium is intact in the anterior portion. However, there is a discontinuity in the posterior end, that is the occipital region. And the brain tissue, along with the overlying meninges, is herniating out through the defect. It looks like this. So this is occipital encephalocele, the most common type of encephalocele. However, there might be parietal and frontoethmoidal types. Now, when we see this, we should ideally go and look for kidneys, for the polycystic kidneys, and also check the digits for polydactyly, because we know the Mickel-Gruber syndrome and the triad of Mickel-Gruber syndrome, and that's autosomal recessive in inheritance and has a high risk of recurrence. Coming to the next case, we see this fetus definitely doesn't look normal, and the spine is hyperextended and it's fixed in this position. And this is a book picture. So the fetus looks exactly like this book picture. So this is a rare malformation with cervical dystrophism, and it might be associated with encephalocele or without it. So the head is hyperextended and there is spinal dystrophism. So this is called as iniencephaly. Coming to the next, here we see the anterior abdominal wall has a defect and the bowel loops are herniating into the amniotic cavity. We can see the insertion of the umbilical cord, and it is normal. And the defect is slightly lateral to the normally inserted umbilical cord. So this is gastroschisis, and we know that there is no covering to it. So that's why we get this irregular appearance, which resembles a cauliflower or a broccoli. This is the picture of the abortus, which shows the herniated bowel loops and a normally inserted umbilical cord. Now, gastroschisis has low association with aneuploidies. Coming to the next case, here we can see a similar herniation from the anterior abdominal wall defect. However, the insertion of umbilical cord is on the apex and we can see a smooth lining to it. So that means that the herniated bowel, or in sometimes if there is liver also, it is covered by parietal peritoneum and amnion. So this is exomphalos. We can also see this in the clip. Now we should note that there is something called as physiological herniation of the gut, which is present till 10 to 11 weeks, and there it normally gets the physiological herniation disappears. And that's why we should make a note that when we see it in earlier gestations, it's a normal phenomena. However, when we see this kind of herniation beyond 11 to 12 weeks, then it is called as exomphalos or omphalocele. The smaller ones are markers for aneuploidy, and the larger ones, and once we have ruled out aneuploidies by doing an invasive procedure, the smaller ones, most of them may resolve spontaneously. Now, this is the same case which had zonophallos, but there was one more finding. So we can see here there's one lower limb and all three segments of the lower limb. So that's the leg is seen. However, with a lot of effort, we couldn't see the other lower limb. And after termination, this is the photograph of the abortus. Here we can see the anterior abdominal wall defect and one lower limb, and the other one was missing. So this is a case of missing limbs. This is an old case where we could see all three segments of one lower limb. However, the other leg was not appearing normal. So this is a case of unilateral absent foot. Here we can see in this clip, it's a twin pregnancy, like chorionic diamniotic, and one fetus was showing a large hypoechoic structure arising from the pelvis. So this was fetal bladder, which measured 37 millimeters. So it was gross megacystis. Now, how do we know it's a bladder? When we see the umbilical arteries on either side of the bladder and by putting on the color Doppler. So we, of course, know that this is a marker for aneuploidy, and the cutoff for megacystis is 7 millimeters. When we see such gross dilatation of the bladders, most of them have associated obstructive pathologies. Now here, anybody who doesn't have an experience and is even a beginner can make out that this is not a normal appearing fetus. There is a gross abnormality and it is always detectable. However, it requires a little bit of skill and experience to know what exactly is going wrong here. So we can see the body is not moving, there's no umbilical cord, it's a short cord, and there is the body of the fetus is partly in the amniotic cavity and partly in the coelomic cavity. So this is a body stalk anomaly, and it's obviously never to be missed. It cannot be missed. However, to make the diagnosis, we will require a little bit of experience and training. So this was all about the always detectable abnormalities. Now, what about neuromarkers? What do you mean by neuromarkers? These are pointers to assess the structures in detail so as to increase the detection rates of anomalies. Now, what do I mean by this? This is the first marker, that is intracranial translucency, which was described by Professor Rabichawi and the stalwarts Professor Nicolaides group. And the femur-shaped structure which we see is the thalamus, midbrain, brainstem. And then the cystic structures are intracranial translucency, the cisterna magna, and the nuchal translucency. So we have to see in the mid-sat section of an NT image, all these hypoechoic spaces which are separated by 3 echogenic lines. And it was proposed that when there is open spina bifida and the caudal displacement of the brainstem leads to complete obliteration of the intracranial translucency and sometimes cisterna magna. So this is a pointer towards open spina bifida, and it prompts us to go and look at the fetal spine in detail when we see such finding on our routine NT image. So what happens in an open spina bifida is that there is caudal displacement of brain, apparent thickening of brainstem. So the BPD is small. The brainstem to occipital bone distance, the DSOB ratio is more than 1. And there is obliteration of intracranial translucency, as I have explained. Now, we'll have a look at how does this happen. So this is an animated picture to just explain the pathology in detail. Here we can see this rectangular structure, which is the aqueduct of Sylvius and the cerebral peduncles and basically the brainstem, and we can see how it is getting displaced posteriorly and downwards and leading to obliteration of aqueduct of Sylvius. Also note the shape of the brain, how it gets compressed. So the BPD is now below 5th centile, and we can obviously see the changes in the posterior fossa. This mid-sag animation shows how the brainstem gets displaced posteriorly and hence results in the distance to the occipital bone reduction and the ratio being more than 1. So what are these? These are obviously not diagnostic signs. We just have to go and look at the fetal spine in detail. If TVS is the best way to look at any fetal anatomical structure to get a very good delineation, and almost always we can diagnose these abnormalities. Now the next marker is the maxillary cap. Here we can see a small rectangular, so this is the maxilla which we have to see in entirety. However, in cases where we find this gap here like this, it was reported by Rabichawi and Professor Nicolaides group that it's a marker for cleft lip and palate. So If we see this in a routine NT section, then it points us to have a detailed look at the fetal palate. And it is simple because there's no additional view required to see this marker. But diagnosis has to be confirmed in axial and frontal views with direct observation for the cleft. Now, Sepulveda et al. Described this marker, which is a retinonasal triangle. The apex is made by nasal bones, the vertical limbs by the maxilla, and the base by the alveolar ridge or the primary palate. And this is the mandibular gap, which we should ideally see in normal fetuses. If we don't see this, then we can suspect the presence of microretrognathia. And cleft lip and palate, the cleft palate can be suspected when we see gaps here in the maxilla. And of course, when we are going to assess the nasal bone, when we have a doubt that one of it is absent, then this view helps us to assess the nasal bones further. Here we see there is a protrusion in the mid-sat section. This is the premaxillary protrusion. And this is seen in cases of bilateral cleft lips and palate because of the small mass, the intervening soft tissue being protruding forward as it doesn't have a support. So this is seen in facial clefts, especially bilateral clefts. Now, a study conducted at our Center of Bangalore Fetal Medicine Center, we found that there are X and V signs in the first trimester to diagnose abnormalities in the heart. So here we see a normal clip of color Doppler showing the fetal 4 chambers of the fetal heart as well as 3 vessels. So this X is a normal sign of crossover of great arteries. V confirms the presence of the outflow. So this is Archer's view. So we should normally see these views. If we do not see this, then we can suspect major heart abnormalities. This sign was first described by Professor Simon Ma. And as we've seen, the V-shaped structure is the 3-vessel Archer's view, which we should normally see. But if we don't see that and we see this kind of image, which looks like a reverse boomerang, then it is a marker for TGA, that is transposition of great arteries, because of their parallel alignment. So this study, which was published by Karim et al. In 2017, showed that detection rates for first trimester anomalies ranged from 32% in the low-risk group to as high as 60% in the high-risk groups. And that's why we need good international protocols with standard views to optimize our detection. And this recent study is a state-of-art review, which was published in 2021. It denotes that we have come a long way from just assessing NT for Down syndrome to now doing a detailed neurosonogram in many planes, axial as well as coronal. And it's an insight in what the future holds and stresses upon the fact that first trimester scan is a real window of opportunity to diagnose most of the problems. And this is an example of inverted pyramid of antenatal care. I'll just show you a few interesting cases. Here we can see the filling is good in the right side of the heart. However, there's no filling on the left side. So this was a case of hypoplastic left heart. And since we normally see those 2 jets in the 4 chambers, we can easily diagnose these cases in the first trimester. This is pretty obvious because the spine has a defect in the lower lumbosacral region. So this is open spina bifida, and this is a 3D rendered image, which shows the defect in detail. This helps us to explain the problem to the couple. Yeah. So this clip, this is a section of the fetal thorax, actually. We can see the fetal heart, 4 chambers is bleeding. However, the fetal heart seems to be displaced to other side. And there is one small hypoechoic structure, which is actually fetal stomach, which has been displaced up high in the thorax. So this is a case of congenital diaphragmatic hernia, left-sided, causing the shift of the heart to the left side. So pretty obvious that we can diagnose this in the first trimester. In this fetus, we can see the hypoechoic septate bulges in the neck. So that was cystic hygroma. We can even see the septations and the nuchal ligament, which is diagnostic of cystic hygroma. And as we scroll down through the body, we can see there is gross subcutaneous edema all over the body of the fetus. So this was cystic hygroma progressing to fetal hydrops. This was an interesting case. Here we can see the fetal heart, which is beating outside the thorax. Also a large anterior abdominal wall defect with exomphalos. So This is diagnostic of pentology of Cantrell, which is a rare abnormality. However, it is pretty obvious because of the large defect in the thorax as well as the upper anterior abdominal wall, the defect in the sternum and the pericardium, causing the heart to lie outside. And it may have variable presentation, but this is the most severe type of pentology of Cantrell. When we saw this fetus, we initially thought it's gastroschisis. Then we thought it's exomphalos. However, the problem was a large anterior abdominal wall defect. This was insertion of the umbilical cord. And along with the anterior abdominal wall, there was a spinal deformity. We can see the kyphoscoliosis. So when we searched for such cases in literature, we found that this most probably was the first trimester manifestation of omphalocele extrophy imperforate anus spinal defect, so OEIS complex. The only thing which we cannot assess at this point of time is the anus, the imperforate anus. Now, this is an interesting case. When we first saw this case, we thought probably it is acrania, or probably it is holoprosencephaly, or some bulging looks like encaphalocele. However, the problem here was that the cranium is absent and the cerebral structures are enclosed in this membrane, which has a smooth contour. And between the membrane and the brain structure, there is this hypoechoic space, the black space, and this is called as Barrett sign. Now, what's Barrett? Barrett is a round cap which is made up of cloth, and it is a little flat like this. And this is the picture of our fetus, which looks exactly like that of the Barrett. So this is a Barrett sign which is seen in cystic acrania. So this was a case of cystic acrania. And this happens when there is acrania, exencephaly, anencephaly sequence. So when there's acrania, the skull is absent, the brain is exposed to the amniotic fluid, it undergoes disintegration and lysis and gives this kind of appearance. If we see these cases in the second trimester, it will be looking like, it will be a secondary anencephaly. This showed the bulging in the neck, so obviously cystic hygroma. However, there was also one more defect, this bulging on the posterior aspect of the fetal brain, which was occipital encaphalocele. So these cases just show us that we do not always get a book picture of anomalies, and there might be a mix and match of so many abnormalities, and that's why it requires skill and a certain amount of updating and training to do this scan. But however, if we do that, we can assess all of the structural anatomy and detect most of the abnormalities in detail. So the limitations are, of course, training and experience. And one more major limitation is presence of anomalies with progressive pathophysiology. For example, corpus callosum or cerebellar vermis, these structures are not formed in the first trimester. That's why diagnosis of abnormalities associated with these is not possible so early on. There are numerous benefits. Early detection, exclusion of major anomalies helps us reassure the expecting mothers. If we find such kind of abnormalities, we can go on to do further invasive testing and genetic diagnosis. And that helps us to explain the scenario to the couple about the recurrence rate and how are they going to progress in their next pregnancy, any pre-conceptional testing if it is required. Of course, easier pregnancy termination. I wouldn't say easier. Any pregnancy termination is not easier, but definitely safer, as we all obstetricians know, that the first trimester termination is comparatively safer as compared to the second trimester. So all of this represents that this is only a beginning of what is achievable for first trimester anomaly screening. And I also conclude my talk with the same slide. If you look, you will find. The only difference is that we have seen and we have found. And we were successful in inverting the pyramid of prenatal care in case of fetal defects too. So it's better to be too early and have to try again than to be too late and have to catch up. I really thank you all for your patient listening.
Thank you, Priya ma'am, for very informative and comprehensive presentation. Ma'am, one question is there from Tripti ma'am. Is this Pinocchio type of nose in your previous peak is normal?
I didn't get you. Can you just repeat the question?
Ma'am, that is in chat box also. Pinocchio type of nose. Ma'am, one presentation, previous peak when you were showing now.
Maybe that was in the acrania, right? So I showed a clip in which the fetal head was obviously abnormal, the cranium was absent, and the fetal brain was elongated. And that's why probably that nose looked like the Pinocchio type. So it's not normal, it is abnormal. And a marker, that case was of acrania.
Thank you, ma'am. Thank you so much. Any more questions from audience? Thank you, ma'am. So the next talk is from Dr. Pratima Radhakrishnan, ma'am. She is a director and consultant at Bangalore Fetal Medicine Center, director IME BFMC Fetal Center, and consultant in fetal medicine Manipal Hospital, also consultant in fetal medicine and scientific director of Lilac Insight. Sita Ramamurthy, ma'am.
Sorry.
Sorry, ma'am. It's my mistake. It's a Pratima Radhakrishnan, ma'am.
Has Madam joined? Purva, please make Madam co-host.
Yes.
Please make Madam co-host, please.
Thank you very much. I've been trying to unmute myself for a while and also start my video. This is Pratima here. Good morning, everybody. And also, if you allow me to share my screen, that
Yes,
will be lovely. Yeah, thanks.
Before Madam starts her presentation, it's a request to all the delegates and participants to mute themselves and avoid the speaker getting disturbed during the talk. So sincere request to everybody.
So, can you see my screen?
Yes,
Yes,
ma'am.
ma'am.
Okay.
Yes, ma'am.
So we will start off on how. I mean, that was a lovely, a very good morning to everybody. And thank you very much, MOGS and team, to Dr. Rahul Vani and the entire team of NMOGS for giving me this opportunity to come back to you again with another important aspect, which I'm expected to cover in 20 minutes, and I will try my level best. But you're free to interrupt me and stop me if I'm going too long. After we have seen how important it is to do the first trimester scan in singleton pregnancies, I think that pretty much same applies to the twins as well. I think there's some background noise. If that can be muted, that will be nice. There's a lot of background noise coming from somewhere. Okay, thank you. Okay, so we're going to see how we're going to apply this to twin pregnancies. Okay, now coming to twin pregnancies, there are again number of things that is very important to look for in the first trimester, and in this talk we are going to stick to these aspects of the first trimester in twin pregnancy. Now, we must understand that the zygosity refers to the type of conception. There is a difference, and the chorionicity is placentation. And on the ultrasound scan, what you're seeing is the chorionicity, and that is what determines the outcome of the pregnancy. I'm going to repeat this again and again. One must remember that when you see dichorionic placenta, that means there are two placentae. 80% of them are dizygotic. That means there are two different conceptions. However, 20% are monozygotic, and this is very important in aspects of aneuploidy screening as well, and particularly when it comes to invasive procedures, and I will talk about it again. Okay, now it's very important to count the number of sacs and the fetuses, and we always start in the early pregnancy by counting the number of sacs first, and it's important to go in that order. First, count the number of sacs. There are 2 sacs. Count the number of fetuses in each sac, that is 1 and 2, and then you look at the cardiac activity, and this is best done before 10 weeks. Somebody's unmuted themselves. Can they mute themselves, please?
People can see my face.
Okay. So coming to the chorionicity and amnionicity, you could do a transabdominal or a transvaginal scan. Look at the placenta. Fetal sex and the thickness of the membrane is not a great sign. What is important is to look at the twin peak sign, and I will come to it in a minute. So if you have 2 discrete placenta with discordant gender, of course, gender would be difficult to determine in the first trimester, then it's a dichorionic twin pregnancy. So presence of T sign, lambda sign, number of placenta, you look at the 11 to 14 weeks, there's got a high accuracy of over 99%, high sensitivity and specificity. So if you see the lambda sign, as you can see, where the chorionic leaf extends into the amniotic membranes, then that is a dichorionic placenta. Whereas if the lambda sign is absent, in other words, some of them call it the black lambda as well, called the monochorionic, where and also the membrane is thin, it's got a high sensitivity but even higher specificity. So that's a monochorionic twin. Okay. Now, of course, there are unusual combinations. You can have a trap sequence where you have one completely normally formed baby and the other baby, only parts of the body is formed, and this baby just basically lives off the normal baby. That's the twin reverse arterial perfusion syndrome, and this is best diagnosed in the first trimester as well. Okay. Now, the other combination you can get is a dichorionic pregnancy with one normal baby and molar placenta with no fetal pole or no fetus in the other sac as well. So you can get various combinations of that as well. However, you must remember that there are certain pitfalls. You can rarely have discordant fetal sex in monochorionic. You can have separate looking placental masses in monochorionic as well. There are false negative and false positive of lambda signs. If you're not careful, you can fall into that trap. The intrauterine synechia can be mistaken for membranes, and especially amnionicity, looking at before 8 weeks, you can mistake them for Mo twins, that is a monochorionic monoamniotic twins. So in amnionicity, I would always wait for the 12-week scan before confirming the amnionicity. And of course, when there is severe TTTS, the membrane is very close to the smaller baby, and you can confuse that to a monoamniotic twin pregnancy as well. And very early pregnancy scans, especially before 8 weeks, there is a lot more errors that can happen, particularly in monochorionic twins. Again, coming to dichorionic placenta, remember 80% are dizygotic, 20% of monozygotic. Labeling in twins in first trimester can be a bit challenging, and it does not depend upon the presenting twin, because we know that twins can go up and down. There is plenty of space to move around, and therefore it does not depend on the twin. It depends upon the sac, and the sac which is closer to the cervix is known as sac 1 and the other one is sac 2, and then you start orientating them as the one which is lower down, where clearly the membrane is across. You have the one which is closer to the cervix is baby 1, and the one which is on the top is baby 2, of course. Or you give a left-right orientation, that is a lateral orientation. The baby on the maternal left is baby 1 and the baby on maternal right is baby 2. And here, of course, if the baby moves up and down, it doesn't matter. Can we please mute the other people? There are some people again who are unmuted themselves. I'd really appreciate that. Thank you. And of course, look at the placental position as well, describing the left and right. Now, when we are labeling twins and more than twins, we always tend to go anti-clockwise. You go maternal right, maternal left, up and down. Describe the placenta in that sac, whether it could be anterior, posterior, right or left lateral. If there is anomaly, we say that anomaly in fetus twin 1. And of course, if there is a smaller baby, you say smaller twin 1. So basically, the description has the report has to be descriptive, and this is what I tend to use. This is a dichorionic twin pregnancy with discordant growth or discordant anomaly or concordant growth, concordant anomaly. You can say whatever you like. What is the situation? Twin 1 is on the maternal left with an anterior placenta and closer to the cervix. This is very important because in the subsequent scans, it will become in the subsequent scans, it will become easier for the operators and you yourself also to be sure which one you've counted as baby 1 and baby 2. Twin 2 is on the maternal right with the right lateral placenta and smaller twin of the two. So you need to get descriptive about all these things and spend time in making sure that you have labeled them correctly. Now, coming to screening in twins, which is a very important aspect of the first trimester scan as well, there are multiple studies which have been looked at, looking at the ultrasound sensitivity and specificity or detection rate, and NT screening and nasal bone. NT screening particularly is highly sensitive. Nasal bone, however, can be limited because of the position. However, now that the NT and the NV are measured in the same view, to be honest, I don't think there a lot of it holds valid, because also note these, some of these studies are quite old as well. But all in all, screening in with the NT is highly has got a high detection rate in twin pregnancy, with an average of 80 to 85 in dichorionic, 80 to 90% in monochorionic, with slightly higher false positives, particularly in monochorionic, because there are other conditions in monochorionic placenta that can present with discordant NT as well. Okay, so first trimester combined test is also pretty valid, and the NT distribution is pretty much similar as in singletons. And the most important thing is you can assess both the babies separately. However, one must remember that the chorionicity can affect the risk of Down syndrome, and therefore in dichorionic twins you calculate the risk separately, and in monochorionic you calculate the average risk. Okay, so this is a study looking at the NIPT, accuracy of NIPT, and they did not find any false positives, and majority of the times with the ones which tested positive, NIPT screen positive, one baby was affected, and of course T21 remained the commonest. However, there was a wide variation in the fetal fraction, particularly in the same gender twins, that's the male-male twins. However, a little bit less variation in the male-female twins. So this is the issue, because you may have fetal fraction which may not be so reliable. But all in all, NIPT seems to be performing well in twins as well when it comes to major chromosomal abnormalities, particularly trisomy 21, right? There is limited data, but it is certainly getting better. If there is a discordant anomaly or discordant markers, it is best to avoid NIPT because it adds to the confusion, because NIPT, remember, is not discriminatory. However, if both the babies are looking pretty similar, concordant, it is reasonably acceptable because a negative test will be quite reassuring. However, if it is screen positive, then you don't know which is the affected baby, and therefore it is absolutely mandatory to perform a double amniocentesis in these pregnancies, right? So in case of vanishing twin, now we know one of the most important causes of vanishing twin or abortion or miscarriage, early pregnancy miscarriages, is chromosomal abnormality. And therefore, in these situations, if you do cell-free DNA, there is a high probability of getting a false positive, which could be having affected the other baby. And in these situations also, it is better to avoid an NIPT test. So screening for aneuploidies in twins. Maternal age is definitely not alone. Maternal is not sufficient. Maternal age with fetal nuchal translucency is acceptable. You add the serum markers, it helps to reduce your false positive rate. You can do the integrated serum screening NT with the first and second trimester serum screening, cell-free DNA as I described, and it is very important to explain these things to the patient. Spend extra time, because extra time spent now when you're counseling them is far better and more effective than spending time when they have abnormal results, because that leads to a shock to everybody. Right now, there can be situations where you can have discordant CRL, discordant NT, and again, how you would deal with it would vary and would depend upon the chorionicity. Slightly different for dichorionic and monochorionic twin pregnancy. I'm not going to go into the detail, but all in all, this is what we tend to follow. If there are discordant twins, we go only with the NT scan. However, if they are concordant, that means both are looking pretty similar, then we would do go with the combined test, and in certain situations, cell-free DNA testing as well can be offered. Now, coming to the invasive testing and procedures, of course, we can do in the first trimester, what we would be doing is the CVS, of course. You can do a double or single CVS depending upon the chorionicity. And I mean, even in monochorionics, it's possible to do double CVS. You would take the edges of the placenta, because I told you sometimes you can have discordant chromosomal abnormalities even in monochorionic twins, right? Early diagnosis helps, and of course, early diagnosis can lead to reduction if it's found to be abnormal earlier, and therefore the risk of miscarriage is also much less when we perform fetal reductions before 16 weeks. Of course, there is a procedure related loss, which is 2 to 5%, and this increases with the increasing number of fetuses, but in twins, of course, it's only one. And what is very important is there are times where we have had to perform CVS prior to doing the reduction, and even in those cases, it's not exceptionally high, the risk of loss. So in good experienced hands, the loss rate can be quite low, even if we have to perform CVS. Now, coming to screening for preeclampsia in twins, we know that twins are already increased risk of developing preeclampsia. So they already start on a high risk basis. Now, we looked BFMC, we looked at the uterine artery Doppler in 309 dichorionic, 102 monochorionic twin pregnancies in the first trimester, and compared them to 10,000 singleton pregnancies to see how the uterine artery varies in twin pregnancy. And what we found was interesting. The median in singleton pregnancies was 1.65, whereas for all twins it was lower, 1.4, 1.5 for the monochorionic, and 1.35. So we know that the median is less. And what was also very important is the monochorionics, and that all twins developed preeclampsia and selective growth restriction at a lower uterine artery PI threshold and higher. So it is important that we should consider the uterine artery PI thresholds lower, although we don't have at this moment of time us any kind of guideline as to what should be the thing, and this correlates with all the other studies as well. So the fact that they're already at increased risk, more likely they are going to be, and they are going to be monitored closely any which ways. But as an obstetrician, it's good for you to be aware that the uterine artery PI thresholds is different in twin pregnancies compared to the singleton pregnancies. So we need to, what we had suggested from the study was that we need to have different cutoffs, and chorionicity must be considered, because again, mono and dichorionics are a bit different, where the monochorionics are more closer to the singletons than the dichorionics. With that, we'll come to the complications in monochorionicity, and most of you are already aware that there is a discrepancy in fluid, which is twin-twin transfusion syndrome, discrepancy in size, which is selective growth restriction. You can have discrepancy in congenital in defects, and of course twin anemia polycythemia syndrome, and about 1 in 3 monochorionic pregnancies can run into trouble with any of these. The other situation is the twin arterial perfusion syndrome, and this is a paper that we published last year looking at the outcome of twin trap pregnancies, and we had about 7% of trap in 234 monochorionic pregnancies, and of course 1 in 4 terminated the pregnancy. The termination rate is high, and of the 13 they were offered expectant management or interstitial laser. About half of them chose interstitial laser, and the outcome in the group which had interstitial laser was far better. We had a more than 60% more than 60%. Sorry, we had 100% live birth rate in the ones which had treatment versus a very high loss rate. Only 2 of the 6 babies with expectant management survived, because they all tend to develop polyhydramnios and early second trimester. Early to late second trimester, and then just ended up with miscarriages, so which was sad. So the tendency now is to diagnose trap early in pregnancy in the first trimester and offer them interstitial laser at that point of time. So this is the conclusions of a study, and interstitial laser, we found it to be safe and feasible option with good outcomes in the management of trap as well. Coming to the Momo twins, and it's not uncommon, and many obstetricians get very worried when they see monochorionic twins and monoamniotic as well. Of course, diagnosis, as I already mentioned, is best done at 12 to 13 weeks. There is no intervening membrane, and I would always recommend doing a transvaginal scan as well to ensure that cord entanglement is always present. There's nothing to be panicky about cord entanglement. It entangles and it untangles as well. So it is always present, and even in the first trimester, this was a 17-weeker, and you can see how much the cord was entangled, and there's nothing much we can do. And surveillance is the same as all monochorionic diamniotic. No intervention is done unless there are any complications, and there is a tendency or the recommendation to deliver these at 32 weeks. I try to extend it to 34 weeks by cesarean section, right? Because there is a risk of sudden death after that, and therefore there is a need to deliver them late preterm. Now, coming to screening, how do we screen for complications? And it is possible to do that. And again, there are, it's very important, as I already said, there is nothing called twin pregnancy. They must be, baptized as dichorionic or monochorionic. And of course, there can be sometimes a single fused placenta, but it must be described as what it is likely to be. And the monoamniotic, I've already said. The monitoring for all monochorionic pregnancies really starts in the first trimester itself. Now, this is a study also we published last year, which is very, very useful. We looked at discordant crown rump length, discordant nuchal translucency, discordant abdominal circumference, and we just to make it uniform, we put it as 10%. And we looked at all these what we called as markers for the possibility of developing complications in isolation and in combination at the 11 to 13 week scan. And we looked at the outcomes, particularly GTTS, selective SFGR, and single and double intrauterine fetal demise. About 60% had complication, we had about 30% that developed complications, 70% did not have complications, 30% that developed complications, and majority, 60% of them were developed before 20 weeks. We looked at the markers, and we found that as the number of markers, these three markers, isolation and in combination, no markers, 1, 2, and 3, as the number of markers increased, there was a higher risk of complications. And in the absence of markers, if there are no markers at all, only 1 in 6 will develop a complication. Right? Coming to isolated markers, looking at the accuracy of discordant abdominal circumference, discordant NT, and discordant CRL, the discordant abdominal circumference performed better than nuchal translucency and crown rump length. Just give sorry, my apologies. Okay, so when it comes to abdominal circumference, when it comes to isolated markers, the abdominal circumference performed better than discordant NT or discordant CRL. Okay, then when we combined the markers and looked at various permutations and combinations, the discordant NT with the discordant abdominal circumference had the highest prediction of at least one complication, particularly before 20 weeks. So this combination worked the best. So the conclusions of the study with isolated marker did not predict significantly, which is what majority of the studies have said as well. The presence of at least 2 markers could predict antenatal complications, and majority, about 60%, had complications. And when we combined discordant NT with discordant AC, it was the strongest, and it predicted 80% of these pregnancies that develop complications, and many of them before 20 weeks. Now, the ISO guideline, I think, is something very important that every obstetrician must be familiar with, particularly when you're dealing with large number of twin pregnancies. And that clearly gives you a guideline that after your first trimester scan, there you have made sure the dating is correct, you have labeled the chorionicity, you've done the screening for trisomy 21 and all the other screenings as well. In monochorionic twin pregnancies, you would be adding further scans at 16 and 18 weeks, looking at the growth and the DBP and the umbilical artery PI. And at 20 weeks, of course, you would look at them, all the twins, dichorionic and monochorionic. And the monochorionic, you will continue fortnightly scans if they're concordant, and in dichorionic you would do 4 weekly scans if there is no discordance, which means if there is discordance, then you would do them more frequently, probably weekly or even twice a week in monochorionic, and even earlier in dichorionic twin pregnancy. So the way forward for twin pregnancies to best outcome is no other way, and there's only 3 things which is very important: early diagnosis, early referral, and early treatment. And this is the only way we can optimize outcomes in these twin pregnancies. Thank you very much.
Thank you, Dr. Pratima. At the outset, as the president of Navi Mumbai Obstetric Gynec Society, I welcome all the faculties, Dr. Sachin, Dr. Priya, Dr. Pratima, Dr. Sita Ramamurthy, Dr. Hari, Dr. Anita Kaul, Dr. Pooja Lodha. I will take a few questions before we move on to the next session. Madam, you said in twin pregnancies, when it is dichorionic, you can take different NTs and you can combine it with the double marker and give the risk of the fetus having chromosome anomalies. Now, if it is monochorionic, you said you take an average NT. So will that really help in
Yes,
categorizing
that's the best way. That's the best way. They've looked at it differently because they both are coming from the similar cells, and the best way is to take the average and not the higher risk, right? Because we know that discordant NT can be a marker for early TTTS also. So if you take the higher, you'll end up with more false positives.
The other thing is, if we have diagnosed a twin pregnancy and there is one single fetal demise, should you go for the combined test of NT plus?
No. If you have a single fetal demise, you can have biochemistry from the other placenta, from the dead placenta, that can cause error in the measurements of the overall. So if you have a vanishing twin, that's what I said, vanishing twin, no biochemistry. Now that includes NIPT and that includes serum biochemistry as well. So better to avoid it. But now again, people have seen whether if the demise has been more than 4 weeks ago. For example, you started off as a twin pregnancy at 6-7 weeks, you saw 2 heartbeats, and then at 8 weeks you had only 1 heartbeat, and at 12 weeks you're doing the NT scan and you just have a very teeny weeny CRL. The idea is that placenta can probably, that twin's placenta probably has died off, right? And therefore it will not cause too much error in the management or in the measurements of the overall serum biochemistry. So maybe in those situations, exceptionally, you may be able to take, but be aware that you're going to get slightly higher false positive if you have that kind of situation. But you need to be aware. But if it is like, you have a fully measurable baby, 10 weeks, the head and body formed at 10 weeks, and at 12 weeks you're doing the NT scan. In those circumstances, I would say better to avoid serum screening completely. And when I say serum screening, please remember NIPT is a serum screen. It's a serum screening. It's not a replacement for diagnostic test. It's a replacement for second trimester quadruple marker test.
Okay, thank you. Any more questions if they are on the chat box?
I think Dr. Anita is in a rush to go, so
yeah.
to talk, and I'm
Thanks.
So I welcome Dr. Anita and Dr. Anita Kaul. The MOC, is the MOC there? If you could introduce Dr. Anita.
Dr. Anita Kaul, ma'am. She's a clinical director and senior consultant, Apollo Center for Fetal Medicine, New Delhi. So over to you, ma'am.
Thank you very much, all of you at Navi Mumbai Society, the president, and especially to Pooja and Sita, who have allowed me to go before them. So thank you all very much. I presume you're seeing my slides. So I chose, and indeed I thought this was an important topic, and that's why I thought that we should talk about preeclampsia, because not only is it important that it's one of the... I'm sorry, someone's talking at the back. So it's not only is it a problem that women die from it, but the reason that it is so important and why it's a public health problem is because women who develop preeclampsia, their life expectancy is reduced by an average of 10 years because they're at increased death from different cardiovascular complications. And even children born of these women, they are more at risk of coronary artery disease and diabetes and so forth. So for us, it is a public health problem. It is something that we as Indians need to understand the importance of, and it is important for us to identify these high risk women so that we can treat them early and therefore improve essentially the next generation. So you remember from our principles of screening that if you have a public health problem, which for us is preeclampsia, there should be a screening test available and there should be treatment available. So this is what I'm going to talk about, and you all know that how aspirin is important. So all societies, because every society thinks that it is a responsibility to issue guidelines for screening for preeclampsia. And, it's not enough. I know that all of us who work in the private sector, we say, well, we hardly see preeclamptic women, but we're not actually just talking about ourselves. We're talking about the Indian society. We as doctors have a responsibility to make sure that we contribute to health measures for all Indian women, and not just think, well, in my practice, maybe I see 2 cases of early preeclampsia a year, and therefore it's not important to me. It is important that we do things which is correct for all Indian women and not just for ourselves. So all the societies have issued some screening guidelines, and the ones which are the most recent are FIGO, which has again issued a guideline recently, and of course the Fetal Medicine Foundation. And you may all be aware that Professor Nicolaides has spent something like 30 years in researching the ways to make a difference in women's health. So when we look at screening for preeclampsia over the years, what didn't work and what is the thing that we used to do is just ask the maternal history, and I'll tell you about that in a minute. But what we realized that it's not enough just to do maybe maternal history, or maybe just measure the blood pressure, or maybe just look at the PLGF, or maybe just measure the uterine artery Doppler. What is important really, if you want to get everything, I get the absolutely the best result, is for you to do everything. And therefore, why it needs to be done at 11 to 13 weeks is because you can identify these cases who would benefit from aspirin. So the FMF guideline, because is part of this inversion of the pyramid of antenatal care, is that you screen at 12 weeks, and then women who are high risk. And I've emphasized this circle because I essentially want you to realize that high risk means a risk which is more than 1 in 100. And this is the biggest change I think the obstetricians need to get into their mindset, that they need to need to think about things in numbers. They shouldn't just look at things subjectively. They need to make everything numerical. So when you're talking about risks, as we do for Downs, your risk is 1 in 300, your risk is 1 in 2000. Similarly, for preeclampsia, we need to be talking about risks. Your risk is 1 in 100, your risk is 1 in 500, or your risk is 1 in 50. It has to be that mindset which we have for T21 screening has to come for preeclampsia screening as well. And therefore, for all of us, and it depends on where we work and what is the population that we're looking at and what is the capacity of the population we're looking at, whether we're at Apollo or at a public hospital, we need to take a call on what is the minimum that you offer for screening. And the minimum, as far as FIGO is concerned and as far as professional bodies are concerned, is that okay, at least take the maternal history, which you've been doing for many years now, but add blood pressure measurements. And what the blood pressure measurement needs to be is the mean arterial pressure. So we have to change the way we think. Now, if we look at the traditional history-based screening strategies, and this is NICE and ACOG and the Australian Society, they all historically say, well, there are certain risk factors and there are certain moderate risk factors. And if the risk factors are high, then you start aspirin. But that is not really the correct way of doing things, because there are pitfalls. One is that there's no prospective evidence. The second is it has very poor detection rate, only 40% if you use the NICE approach. There is no way that these risk factors, if you've got, say, two risk factors, I mean, there's no way to kind of get these risk factors to interact with each other or to de-escalate the risk. So if if say you do a test and you find that the uterine artery actually in a woman who has had a history of previous preeclampsia, but her uterine artery is absolutely normal and in fact it's very good, there's no way you can now de-escalate the risk and say, well, actually her risk is much lower now, and we need to make changes. And lastly, that there is nothing personalized about doing this traditional screening. And the whole ethos of the Fetal Medicine Foundation is to give a patient specific personalized risk. And the only way you can do that is by using computer algorithms. And this is the second most important thing that the next generation of obstetricians will feel, will see that we are doing, because there is no way, all of us at our own individual level, there's no way that we can compute all these different permutations and combinations of risk assessment. And because this is so important, this algorithm on which you can calculate all these risks is absolutely free on the fetal medicine website. So let me show you how it works. Say, for instance, you go to the fetal medicine. Sorry, I don't know what happened. Say, for instance, you decide, and no one is forcing you that you must do preeclampsia screening in a certain way. All we're saying is the preeclampsia screening has to be preeclampsia screening has to be universal, and then depending on your capacity and your patient's capacity, at least do maternal factor and mean arterial pressure. And the more things that you integrate in, the more efficient is your screening and the lower is your false positive rate. So there are less and less people that you need to start aspirin on. So the thing is, you have to learn to use screening algorithm softwares. You have to learn to use it. I'm giving you an example of, say for instance, you have a woman with her, and she is APLA positive. Her risk goes up by 8-fold. But if she is a thin lady, that risk changes. If she's got a BMI of more than 35, then further increase of risk. If she is a primey, there's a difference. If she has, now it's been 10 years since her last pregnancy, the risk changes. So these kind of permutations, combinations, you cannot sit there and compute yourself. You have to use a computer algorithm. And similarly for the mean arterial pressure. The mean arterial pressure, I know that we've been doing systolic, diastolic for many years, but the mean arterial pressure is a better indicator of perfusion to vital organs than just doing systolic blood pressures. So you need to again swap over, and again, because independently the map gets varies because of gestational age, her maternal age, whether she's a smoker, what's her weight, her height, and all these other things. You cannot compute it yourself. You need to use a algorithm. I'm going to spend a few minutes just telling you about measuring a mean arterial pressure, because it is something which is so important. I mean, we have to start doing it. So as you can see here, the best thing for us to do is use a phlebotomy chair, which is very easily available. Um, in our unit, we have a microlife which has a armband for both for the both arms, and when we inflate it, the the measurements come immediately, so it is quite easy to do. But even if you don't have this, you at least use two machines. And the other thing that I need to tell you is, look at this paper, which is the blood pressure measurement devices to be used in pregnancy. So you cannot just use any device, because it's thought that if these pregnancy devices are not validated for women, you may be under measuring them, that they actually have got a slight rise in blood pressures, and you're passing it off as normal. So look at this particular paper, because as the paper goes on, there's a list of all the devices which are validated in pregnancy. So use that. So I do believe that we really need to start doing it. If you're not universally doing this, you must. And then using this software, which is on the fetal medicine foundation.org, all these risk calculator softwares are there, so you can use it for everything. So for preeclampsia, and I'm just giving you a basic example, all this needs to be filled in: the maternal characteristics, her history, her biophysical markers. I mean, if you this opens out into the left arm, right arm, first reading, second reading, so it gives you an average of things. If you like with if you want to use the biochemical markers, which we advocate, but anyway, even if you can't sit there and click that you're not going to use it, and then on the basis you will get preeclampsia risks. Now, say in this pregnancy, her risks are extremely high and she would be started on aspirin. But because the false positive rate can be a little bit higher if you use just a few risks, if you use biochemical, and this is another sort of contingent screening approach you can use, that you say that, okay, let me just do the basic stuff. And the ones who are coming as high risk, as came in our patients, maybe in those we would add uterine arteries and the PLGF. The the point is that you need to decide for yourself. The gold standard is using everything, but if, say, you find it expensive, you feel that your patients can't afford it, then you can bring it down to a sort of minimum requirement, which is history and map, but at least do universal screening. So, when you do universal screening, the ASPRE studies, I mean, this is like a seminal paper which has absolutely got well established that the risk reduction is has been 80%, and this was with about 89% compliance, which means that they realized when the study was going on that not everyone, you may think you've started women on aspirin, but it is not necessary that they actually take it every day till delivery. It is not necessary. And it's only, and that is the reason that we say that you should not prescribe it to all pregnant women, because a lot of obstetricians think, oh, well, why not just give aspirin? And, FIGO has very clearly said that you shouldn't. I mean, that's another talk to say that what are the side effects of aspirin. But the main issue is of compliance. So if a woman gets a whole litany of medicines, which includes aspirin as well, it is not she does not take it, and religiously day after day until she delivers. However, if you show her a risk and you demonstrate that you've done a risk assessment for her and she's coming into a high risk zone, and if you sit there and take aspirin, you would prevent problems. In about 80% of cases, they are much more religious about taking it. I've just put up this slide on uterine artery Dopplers because I think people give aspirin really. I'm really unhappy about the fact that people just start giving women aspirin just also on uterine notching. You need to understand that 43% of normal pregnancies in the first trimester will have a notch. So that is not what is important. What is important is the mean PI. So you cannot, reports in which they've said there's a uterine artery notch in the left artery and there is no notch in the right artery, or any sonologist who gives you individual uterine artery measurements rather than the mean PI, means that they are not understood the principles of screening and the way of using uterine artery Dopplers. I mean, logically, if you use your common sense, you'll realize that the uterus is not supplied by one half is supplied by one thing and the other half is supplied by the other uterine artery. You have to think of it as a holistic organ, and the blood perfusion as a holistic thing as well. So you need to calculate the mean PI. We again, I'm sure the audience don't do SDs and RDs and all the rest of it. It has to be the mean PI, and even this you can factor into the FMF software. So to illustrate it, I'm just putting up a case. These were the uterine arteries. You would agree that it was 95th percentile. So it was 1.9 moms, and therefore it was high. However, when we looked at all the other things, so when we looked at her maternal history, when we measured her blood pressures, which you can see was plumb normal, and when we factored in, because we universally do PAPE and PLGF, her PLGF was fantastic. So therefore, her risks of preeclampsia was still very low, where we take 1 in 100 as a cutoff. So as you understand very clearly, we talk about numbers. We do not talk about high risk, low risk for preeclampsia. And so we did not start her with aspirin, and she continued to deliver at 38 weeks with a reasonably good size baby, 2.9. So the case has been put up to make you understand that you have to consider the pregnancy holistically. You cannot sit there and say she's high uterine, therefore she's at risk, or she's high high history and therefore she's at risk. You have to look at that patient holistically. You really, really must start using risk calculation softwares. So the PLGF originally came about to bring down the false positive rates of the T21 screening, but it is now increasingly being realized that it is a pro-angiogenic molecule. It supports trophoblastic growth, and it's a very, very good predictor for preeclampsia, to the point that the scientific community and FMF is looking to see that, well, if PLGF is so good, should we withdraw beta HCG as a measurement thing in the first trimester screen and actually just introduce PLGF? And will that make such a big difference to the down screening research? So as you can see, that if PLGF behaves like PAPE, that in situations which are not very good, the PLGF is low, but the higher the PLGF, the better the situation. So this is my last slide, and I'm absolutely absolute advocate for universal screening. And this is a slide from Leona Poon's group, where they've looked at the numbers needed to screen to detect one problem. So say for a mammogram, the numbers needed to screen is 377 to detect one CA breast. Pap smear, 1100 to detect one cervical cancer. Prostate, 1400 to detect one cervical cancer. So these have become so established in our armamentarium. We don't think twice about ordering a mammogram or indeed a pap smear. So why are you hesitant, and why are people still not accepting preeclampsia screening? Because to prevent one case of preeclampsia, you essentially just need to screen 143 women. And as compared to whatever is happening in the other parts of our body, I think it's really like a sort of no-brainer. I do think universal preeclampsia screening has to come in. And the FMF prediction models have been validated in several countries, including India. And I would sincerely suggest to all of you that please use risk calculation algorithms, because that's where medicine is going, and obstetricians need to get used to it. And absolutely do universal screening for preeclampsia. As I said, the gold standard is everything, but if not that, at least do the blood pressure readings correctly and the history. So thank you all very much. Thank you. And
Thank
thank you for letting me go earlier. Thank you.
Thank
Thank
you,
you,
Anita ma'am, for your
Thanks,
detailed
Pooja.
discussion. And we at Navi Mumbai are doing a lot of first trimester screening, especially NT scans and double markers. And this is the next in thing. We want to upgrade this preeclampsia screening. As you said, it should be universal, and that is the whole
Right.
aim, that we need to do universal screening for preeclampsia. Dr. Anuvij ma'am and Dr. Suchita ma'am, you are the co-host. You can unmute yourself and initiate a discussion before we let Anita ma'am go.
Okay, thanks. Anu, which is
Hi,
an old
Anita.
friend.
Hi, how are
Anu.
you?
Nice to
Yeah.
see you.
So, as Rahul told that we are doing the combined screen. So, taking this opportunity that when we are doing combined screen, we are given the preeclampsia screen by default if we just send the uterine artery, mean uterine artery pressure. So that
Right.
is what we have included in our setup. When we fill that form for double marker, we send the mean uterine artery pressure as well, plus
Right.
the maternal characteristics, the history, and the biophysical features. So
But-
we get the report with the aneuploidy screen. The risk of preeclampsia screen also is given to us. That is by default.
Okay, but as I said, the more you do, the better it is. So even if you take the blood pressure correctly, that would add. Because the point is, why are you not doing the mean arterial pressure? It's easier than also doing the uterine.
But then unless we put it in an algorithm, we sitting at our own clinics cannot generate a risk.
But if you're with Lilac, they'll enter it.
Yes, that's what I'm saying.
But
you just have to give one reading.
Yeah, but you're not giving them blood pressure readings.
We are giving them right side, left side, and they are calculating the mean arterial pressure. And then they are putting in the algorithm.
They're doing you are doing 3 things out of the 4.
Yeah.
But you're not doing the PLGF.
PLGF is there in the algorithm.
But lots of people don't order the PLGF. They order the dual marker. They order the PAPE and the beta HCGs.
No. We have requested them in the algorithm for our center. PLGF is included by default.
So
that's how we are doing.
Perfect. Then you're
we
doing
have
the
modified
perfect screening.
No,
so you're doing it exactly according to the FMF criteria, which is great.
Yes. No, but what I mean to stress is everybody can do this.
Yeah.
Everybody.
Absolutely.
Because many people from our area are sending to Lilac only. So if they can do for me, they can do for other people also.
Right. No, absolutely.
I wanted just to add one comment. What Dr. Anita has said so well. I think we all obstetricians can do our part by appropriately and technically correct way measuring mean arterial blood pressure. I mean the blood pressure with 2 BP apparatus, validated BP apparatus, and fulfilling all those criteria. So I think from your lecture, definitely we come to know that we need to screen each and every woman for preeclampsia, but the obstetrician's part, we are used to taking blood pressure in a supine position with the mercury apparatus. I think we need to change that practice and make it standardized. And this can be done even when a paramedic staff sitting outside, in the waiting room. So,
and indeed, it is done by our reception staff. It's not that we measure it.
So I think we obstetricians need to make that small change. And then, of course, the FMF software is there. There is, I think, Justosis organization recommends 75 milligram of aspirin. Any comment on that?
No, that's I maybe they would have upgraded that comment after the Aspray paper came in. But Aspray, they've changed it, I'm sure. Thanks, Pooja. Yeah, so it's 150. Absolutely, yeah.
And any particular reason for taking it at bedtime or evening time?
So the part of the research papers, they looked at the circadian rhythm and they checked the blood pressures at different times of the day. And they found that if you took it at bedtime, it worked the most efficiently. So I'm happy to share that paper with you, but actually they've had papers where they've looked at different times of the day and how did it affect the BP readings.
One more
There's
thing,
a lot of work which has gone on in hypertension, not just for pregnant women, but just generally.
And do we need to stop this aspirin at 34 or 36 weeks?
So you can actually technically give it till delivery, but generally FMF says okay by 36 weeks, but there's no reason for you to stop it. You can keep giving it until she goes into labor. It's not that there's increased bleeding or increased abruptio or there's increase anything. Pooja had once made me do a talk on aspirin and the uses of aspirin in pregnancy. So I had really looked it up, and again there are lots of papers to see how safe it is. So you can take it right till the end, till the
One
ninth
more
month.
small question, like in preeclampsia risk calculation, you get it risk at less than 34 weeks and less than 40 weeks and less than 42 weeks, and one more added FGR risk at less than
Right,
57 weeks.
right.
Now, of these four risks, which
Yeah.
one we need to give aspirin?
Less than 34 weeks. I mean, I give it even for less than 37. So essentially what aspirin does is it kind of delays things. So if she were to develop preeclampsia, say at 28 weeks, it kind of pushes it back to about 34, 35 weeks. So it's not that it's not that you may completely prevent it, but it changes it from early to late. And the late ones it makes even later. But till 37 weeks we do. I don't look at 42. So in my risk calculation software, I've deactivated the 42 weeks because I don't think it makes sense at all. So we only have the 37 weeks. In fact, the new FMF guidelines have also taken away the 34 weeks. They've just left it at 37 weeks. So anyone who has a risk before 37 weeks, she needs to go on aspirin.
And that is 1 in 100. More than
1 in 100,
100.
correct.
And if there is no preeclampsia risk, but there is a FGR risk, does
So-
the aspirin still helps?
So there has, again, they looked at subgroup analysis to see that in the ASPRE study, did the FGR people, would they benefit? So they've said that there's a modest benefit, but not as much as it is for preeclampsia. But for me, initially we would not give aspirin if the FGR risks were high, and we would take it as 1 in 30 for the FGR risks to start aspirin. But now, yeah, we've started. But we should look at data. We don't know if it helps or not, but we think
Madam,
why
one
not
more
give
thing.
it?
Thank you.
One more thing, in your presentation, you showed the blood pressures taken in both arms simultaneously. Is it
Correct.
necessary that it has to be taken simultaneously, or
Yeah,
it can be taken
yeah.
one after the other?
No, it's generally that it's taken simultaneously in both arms to
Okay.
get the mean. Yeah. But I mean, the point is, if you've just got one machine, it's better you do it in both arms. You do what is convenient, but do it. So if, for instance, you don't have two BP machines, okay, do it while first left side, then the right side. But don't not do it.
Thank you, ma'am.
Okay.
And also it is
Thank you very
important to
much.
measure it twice, like make at least total 4 measurements, right?
Yeah. Okay, thank you very much. And thanks, Pooja, again for bailing me out. Thank you. Bye.
Thank you, ma'am. Thank you for this very informative and crisp presentation. The next presentation is Dr. Pooja Loda. She is a director of Kangaroo Cradle Fetal Care Clinic, Pune. She is a consultant at Bharati Vidyapeeth and Ruby Hall Clinic, Pune. She held various posts at Fetal Medicine Committee, AMOGS, and Pune Obstetric and Gynec Society. So over to you, ma'am.
Can you hear me?
Yes, ma'am, we can hear you.
And my slides are visible as well, ma'am?
Yes, ma'am. Yes, ma'am.
Thank you so much. Anita ma'am, it's a pleasure to speak after you, and I'm tensed as well. Respected Dr. Rahul Vani sir, Dr. Santosh Jayabhai sir, and the dignitaries from NMOGS, Dr. Anuvij ma'am and Dr. Sucheta ma'am. And special thanks to my friends Sachin and Priya for this talk today on interpreting first trimester biochemistry. It's all in the bloods. what New Jersey is to New York, what downtown is to Dubai, and Navi Mumbai is to Mumbai. So hello Navi Mumbaikars, if I could call you. And I've tried to make this slightly boring appearing topic a little more interesting because Anita Paul ma'am had to switch the talk. We may go from a little more complicated things to the basics, but remember, basics is where it all starts. So I hope this interests you and changes your outlook in the practice. The outline of today's talk is screening versus diagnostic testing, a normal double marker, how to interpret and counsel the couple, abnormal double markers, what next, what is enhanced first trimester screening, and a certain number of truths and myths that we are facing every day. As soon as we hear the word double marker, it's usually a headache for us because there are so many numbers, it's so many words written on that one page that we try to run away from the page and we only look for two words, low risk, and then we jump on the other page. And that's very human for us to do it. But through this talk, I would want you to study the page a little better because then you could use this particular test for reasons more than one and in better ways. Most of us forget the basics and wonder why the specifics don't work. So we forget which test to order when, and we try to interpret the complicated ones and try to do all the new tests on the blog. So let's see some basics. I am using only the points that are relevant to us in day-to-day practice, and this would also kind of form a base for the next talk by Dr. Sita ma'am on NIPS. Screening is for everybody. We don't choose whom to screen. So just like ma'am said, preeclampsia screening for everyone, only then would we know who is high risk and low risk. There was a question in the chat box that said, should we also screen low risk women for preeclampsia? Well, how would we even know whether they are low risk or high risk unless we screen everyone? So screening is for everyone. And why so? Why do we also screen younger women for chromosomal abnormalities? Although we know that the risk of chromosomal abnormalities increases after the age of 35 years, but if we see the number of women that are giving birth, the number is more in the younger age group as compared to the older ones. And therefore, if you look at the absolute number of babies born with chromosomal abnormalities, it is the younger women less than 35 years as compared to those more than 35. So once we screen everybody using a screening test, we find a few women who are high risk and a few women who are low risk. To leave aside the low risk one and just subject them to routine antenatal surveillance, and they usually do not require any further testing as far as screening for chromosomal abnormalities is concerned. Now, looking at the high risk group, you subject the high risk group to a diagnostic test. Now, mind well, the test that you are subjecting the high risk group to is a better test than the screening test. It cannot be the same test and it cannot be a test which is worse than the previous screening test. So do you do a better test, rather a best test, which is the diagnostic test, and then finally declare whether these women who have actually been assigned to the high risk group are normal, they were only in the group by mistake, or they are affected and the fetus is abnormal. So let us look at this from the Down syndrome point of view. Before I start about this chart, why only Down syndrome? Why all this fuss about the Down syndrome? There are so many syndromes, but Down syndrome is the one that is the commonest cause for a mentally not normal baby being born alive and living for many years. It's extremely difficult to deal with this situation as compared to Edwards and Patau that actually hit you in the eye on ultrasound. They are lethal and they do not trouble you for the rest of the life. And therefore, Down syndrome is more of a fuss than other syndromes, also because it's more subtle on the ultrasound. It doesn't always just hits you with gross abnormalities. So prenatal test for Down syndrome, I've limited myself to the first trimester since this is a CME on first trimester. We have screening tests and we have diagnostic tests. Amongst the screening tests, there are two ways in which we can screen the women, either by maternal biochemistry and by ultrasound. On biochemistry, we have the double marker and the enhanced FTS. On ultrasound, we look for the nuchal translucency, nasal bone, and the other markers as we just saw before. Diagnostic tests our chorionic villus sampling in the first trimester. Sorry to include the amniocentesis. It's a second trimester diagnostic test. And of course, our favorite NIPT. And I'm sure the next talk will clear a lot of concepts about NIPT. But all we need to reiterate again and again, as Pratima ma'am also said, you include NIPT in the screening category and not the diagnostic category. Okay. So what actually is double marker? It would be surprising for us to know that PAPE and HCG changes in mothers who are carrying Down's babies dates back to even earlier than nuchal translucency was actually found by Professor Nicolaides. Probably we don't have somebody to push these markers as much as the NT, otherwise they would have been equally famous by now. What is double marker? It is a blood test in the mother. What does it test for? It tests for the common chromosomes, trisomy 21, Down syndrome, trisomy 18, Edwards syndrome, and trisomy 13, Patau syndrome. When is it done? It can be done between 10 to 13 weeks and 6 days. Yes, it can be done even at 10 weeks. Whom to offer? To everybody. So we understood that universal screening is the combined first trimester screening, which includes a double marker and the NT scan, and not just NT scan for low risk women. What is the sensitivity and how do we interpret a double marker? Slides to come will show us those. This is a chart you all have seen many times, but just to stress, if we include maternal age and double marker to diagnose Down syndrome, we would pick up 6 out of 10 Down syndrome and miss 4 of them. We're not doing good that way. Therefore, the combined screening that includes all ultrasound markers that Sachin mentioned to us, and we add on a double marker, and we of course always use maternal age, which is the 4th one here, we can go ahead with a detection rate of as high as 93 to 96% with a false positive rate of 5%. This just means that a simple addition of a non-invasive maternal blood test can improve our detection of Down syndrome. And for all those of you who feel that Down syndrome is still not a big deal, there are more advantages of doing this double marker, and the slides to come will show us that. I was telling you on the page of double marker, there are so many values. I just want to stress on what you should see and what you can ignore. We keep hearing the word moms. All the talks, all the conferences, and all the papers talk about moms. Moms are multiples of median. What is a mom? Mom is the boss, just like our mother is. So unless we convert the biochemical values into multiples of medians, we do not understand their implication in that particular patient. Mom is what the value is versus what it should be. Okay, so I've just taken a simple example. At 12 weeks of gestation, the patient's PAPE value is 1400, which you can really ignore. This is only for the purpose of explaining to you what moms is. The patient's PAPE value is 1400. What is expected at 12 weeks for her age, her ethnicity, her weight, etc., is 2800. And therefore, her moms are the patient's value upon the expected value, which is 0.5 here. So when you look at a report, you can absolutely ignore the absolute values of the biochemical markers and concentrate only on the moms and not just the risks, because the moms are also going to give us ideas about other obstetric adverse events and not just Down syndrome. How do moms vary? They vary with the gestational age, the assay used, population, ethnicity, weight, diabetes, any other comorbidities, any histories in previous pregnancy, and multifetal gestation, which is why when an authentic, calibrated, and accredited lab asks you for a requisition for double marker, they would want all this information from you. Okay, a lab that does not ask you the ethnicity, a lab that does not ask you a weight or whether what type of twins it is not actually doing it the right way. And that's also important why you need to fill the form properly when you're requesting for a double marker, because the software that is going to calculate the risks is going to take all of this into consideration. Now, just simplifying it further, the ideal moms for beta HCG and PAPE are 1. They are supposed to be ideally 1. What happens in Down syndrome and trisomy 13/18? 2 different things happen. In Down syndrome, The beta HCG norms are twice that of normal, and the PAPE norms are half of that of normal. Whereas in trisomy 13 and 18, the beta HCG as well as the PAPE are extremely low. And therefore, unless the maternal biochemistry is extremely abnormal, usually you would not find that a lady is high risk for trisomy 13, 18, and 21, all three together. Because 13 and 18 will require the lady to have very low beta HCG, whereas as we see here, Down syndrome would require her beta HCG norms to be higher. Now, how do we interpret and counsel? Because this is what matters. I've taken a case for that. There's a 29-year-old lady and she's 12 weeks and 3 days today. So this is a good time to do her combined screening. How do you do it? You do an ultrasound. You see that the CRL is 65 millimeters, an NT of 1.6 millimeters, which is very normal within the 95th centile. For this CRL, the fetus shows a nasal bone. Now, when we do her double marker, look at these values. Beta HCG is 36.5. Ignore. Do not look at the absolute values. PAPE is 4.5. Forget it. Look at the moms because our labs here have actually made it very convenient for us and converted it into moms. 1.1 and 1. As I told you, 1 is how it is supposed to be. So 1.1 and 1 is very near the normal. So this lady is expected to be extremely low risk. Let us see how to counsel this lady. We tell her, because all these numbers are going to appear on that report. So she is going to ask you questions. Ye 900 kya hai? Ye 18,000 kya hai? Ye 1.1 mom kya hai? She is going to ask you numbers. So what this basically means is, before doing the test, if sitting in a room of 950 people, she would be one carrying a baby with Down syndrome. After doing the ultrasound and the double marker, we've moved her onto a huge ground with 18,000 people, and now she is one of them, which essentially means that the probability of her carrying a baby with Down syndrome is extremely less. And that is because we've done our screening well and it's all low risk. Now, this new concept that has come up is intermediate risk, and labs have started reporting something known as intermediate risk, and every day we are facing this very commonly. Now, this is again a very complicated page. Like I told you, go to the moms. The moms for HCG is 1.7, which is slightly higher than what it is should to be. PAPE is 0.2. Yes, it is. 1 is normal, so 0.2 is extremely low. It is less than even half. Now, what has the bloods done to the risks? When she started off, her risk was 1 in 936. This is her age risk. This is anybody of her age entering into pregnancy would have that risk. After doing the test, we wanted her risk to go to 10,000 and 20,000. What has actually happened is, despite a normal NT of 1.2 millimeters, her risk has not improved. On the contrary, we've moved her to a smaller room with 405 people, and she is now one of them. So her risk has actually doubled. And why is that so? Because the bloods are not assuring. What have labs done to simplify this report? They've given us color codes so that we don't miss on the intermediate risk ones. And therefore, here we see that our lady here is in the intermediate risk one. So that 1 in 250, say agar risk zyada hai, 1 in 10, 1 in 20, we are alarmed. But usually when the risk is 1 in 600 and 1 in 700, we tend to ignore because the routine labs will just tell you, okay, it's low risk. But no, there's something more than low risk. There is an intermediate risk and some of the downs lie here. Now, looking at the algorithm as to what to do next when you have an intermediate risk, of course, when you do a double marker and a good NT scan, you get a low risk, you do routine screening and no further testing is required. If there is high risk, as per the protocol, you go ahead and do a chorionic villus sampling or an amniocentesis as per your protocol. But if there is an intermediate risk, there are 3 options we have. Either we do an integrated quadruple screening test, which I'm not much in favor of because as you can see, the sensitivity of adding on a quadruple test once you've done a better double marker test along with a good NT scan is almost the same as you were to do a good double marker and NT scan. We just saw it was 93 to 96% and here it's the same. So I'm not somebody who would really encourage a quadruple marker and integrating it if the first trimester is intermediate. Let's clear it up. Like I said, once you do a screening test, you have to step up. You have to do something better. So something better is either a diagnostic test or a better screening test. And the better screening test is NIPT, about which the next talk is. And of course, the diagnostic test is chorionic villus sampling. or amniocentesis. There are some women who would choose not to do any further testing. You do an early anomaly or an aneuploidy marker scan at 16 weeks. You look for markers. If the baby seems fine, you got to tell the couple, look, I don't see any abnormal markers on ultrasound, but you are intermediate risk. I can rule out 90% of the Down syndrome babies just looking at the baby, but 10% I'm going to miss, which the other two tests will pick up. And you leave the platter open for the couple to choose. Now, how do you choose which lab to send your double marker? It's not favoring one particular lab, but study the lab to which you send your double marker. Is it accredited for the person, for the machine, for the method, for the chain, and for the material? Which means, does it ask you for the proper history on the requisition form? Does it collect the sample? There are labs who collect your triple marker test at 12 weeks. Triple marker is obsolete, but they're not even supposed to do it at the wrong gestation. So your lab should ask the gestational age, and there are labs which refuse collecting samples if she does not lie into the correct gestational age. Are they accepting the correct test? The NT is 5 millimeters, the baby has multiple abnormalities, and you want to go ahead and do a double marker? Good labs will refuse doing a double marker in that situation. Is the temperature controlled while transportation? Are the reagents accredited? Is the software for calculation accredited? Is the person reporting and interpreting the risk certified to do so? So there are so many things, especially when you have genetic labs, so many genetic labs coming up. You need to make sure that where you're sending your sample is the right place. Now, coming to another example, exactly the same case like before, but now the age is 39 years. A normal ultrasound, a good NT, and excellent beta HCG PAPE moms. Forget the middle absolute values, only the moms. Now, the age risk is 1 in 120. Does that make her high risk? I've brought this up because a lot of labs will put age risk 1 in 120, high risk. Here, the high risk and the low risk is never the age risk. The high risk and the low risk is after doing the test. Okay, so your priori risk before doing the test depends on your age. Of course, it's going to be higher at 40 years of age than it would be at 20 years of age, but that does not make this particular lady at a higher risk as compared to others, because the risk of 18,000 is what you're looking at here and not the risk of 1 in 120. The risk of 120 is the baseline. That's where you're starting from. That cannot be high risk or low risk. Okay, that's the age risk. Now, coming to another case, she's a 30-year-old IVF conceived. Now, mind you, when there is IVF conceived, there are certain things we need to take care of. You see here that the beta HCG is 5.6 times the normal. It's forget these values. It's 5.6 times the normal. And therefore, her risks are 1 in 257. Okay. Don't scare her away telling her that your risks are not low and go ahead and do an amniocentesis or go ahead and do this and that. Ask a simple history, and if you've sent your double marker to a good lab, they would already have asked this history. Ask for history of exogenous HUCOG injections, whether it works at 12 weeks or not, but a lot of IVF specialists keep giving weekly HUCOG injections, and the routine practices, she's come to you, you give a HUCOG injection, she goes out, gives a double marker, and there you have a very high HCG value on your double marker, increasing her risk for Down syndrome. So it's a simple history that ideally a lab asks, but if not, please you do. Another thing, she's a 41-year-old, IVF conceived, excellent labs, excellent double marker, yet she's high risk, okay? Now, at the age of 41, what you really need to ask is, were her own oocytes used? If yes, there is so much of oocyte freezing and embryo freezing happening. Sometimes the embryos are frozen 5 years back. You are unnecessarily increasing her risk by not taking into consideration the age of the oocyte. So this is another important history that only an accredited lab would ask you. Okay. Coming to PAPE, it's not just Down syndrome. A low PAPE actually is very interpreted with caution, because it is associated with spontaneous fetal loss less than 24 weeks, higher risks for preeclampsia, low birth weight, and preterm birth. So we know that less than 0.4 moms, we are really scared of these low PAPE levels, and you increase the feto-maternal surveillance even if the fetus is low risk for chromosomal abnormalities or the karyotype is normal. Now, coming to IVF conceptions, we already saw that the age is important. You have to ask the oocyte age and not the age of the mother who is carrying the baby. ICSI is associated with higher risks for chromosomal aberrations And therefore, you also need to ask what kind of IVF procedure she's undergone. Multi-fetal gestation, we've heard a superb lecture by Pratima ma'am. Donors and surrogates. Yes, you can scan the surrogate for a double marker because ultimately she's the lady carrying the baby. There's a lot of confusion regarding surrogates. She's the lady carrying the baby and you need to find the risks for the baby. The placenta secretes beta-HCG and PAPA, and therefore you can do a double marker in all surrogates. What you need to mention there is the age of the oocyte donor. So the genetic parents need to be considered for the age, but you can do a double marker. Now, last two slides, there was a question in the chat box regarding vanishing twin and fetal reduction. Excellent guidelines have come up in 2020 by the National Health Services in the UK, and Professor Nicolaides' group has come up with this excellent paper in 2020 where they say if there is an empty gestational sac, there is no embryo, combined first trimester screening can be done, and the serum free beta-HCG and PAPA are no different from those in other singleton pregnancy. In short, an empty sac without an embryo, go ahead and do a routine combined first trimester screening. Now, if at all there is an embryo detectable, there is going to be falsely high PAPA, which is going to be a falsely assuring low risk. So if there is a dead embryo that you can see, if there is a detectable dead embryo that you can see, NT alone needs to be done. By NT alone, I mean the NT scan alone. Of course, you can use all the ultrasound markers, but the serum markers are affected for several weeks. And therefore, please refrain from doing a double marker if you see a detectable dead embryo on scan. In vanishing twin, you may skip the double marker, but this is an unusual situation where you can actually use the quadruple marker because they say that by the time she's 16 weeks, the effect of the dead embryo would have gone on the maternal biochemistry. Now, after embryo reduction, avoid doing a double marker. If you want to reduce from twins to singleton, which we do nowadays for social reasons, do a double marker, do a proper combined screening, and then do a fetal reduction. Do not do a double marker after doing a fetal reduction. And especially for us fetal medicine specialists who reduce fetuses and not embryos, do not do a quadruple test because the alpha fetoprotein is going to be high in such cases because the dead embryo is going to release AFP and she's going to come up high risk for neural tube defects. So after embryo reduction, avoid a double marker and also avoid a quadruple marker. Do it before the reduction, if at all. When not to offer prenatal screening, when there are gross abnormalities on the ultrasound, there is no use doing a double marker. Gestational age is between 13 plus 6 and 15. This is a dead time. You can neither do a good scan nor do a biochemistry. So wait for 15 weeks and then go ahead and do the next marker. Of course, NIPT is an exception to this. If parents have a known familial history of single gene disorders, so if you're anyways going to go in and do an invasive, and you're going to send a microarray or a karyotype or a fish while doing the invasive, like we mostly do as a protocol, do not waste her money on doing a double marker then. There is a fresh ongoing bleeding, avoid doing a double marker. There is a vanishing twin and embryo reduction, we've already seen that. And of course, within a week from the exogenous HCG injection. Last slide, certain myths and truths. Double marker has to be done on the same day as NT scan? Absolutely not. There are people we've seen who miss on doing a double marker because they are NT scan late खत्म हुआ रात को 8 बज गए और double marker का lab close हो गया इसलिए we did not do the double marker. Now we are already 15 weeks. Double marker can be done anytime before or after the NT scan because a good accredited lab is finally going to convert the absolute values of beta HCG and PAPA into moms and not just use the absolute numbers to give you risks. Okay. The moms depend on gestational age. So they will tell you that the scan was done on so-and-so date, the sampling of the blood was done on so-and-so date, and therefore the moms are so-and-so. So give a double marker irrespective of doing the NT scan, of course, between 10 and 13 plus 6 weeks. Double marker is not useful in monochorionic twins. This is a huge myth. We've seen Pratima ma'am speak about it. NT scan and double marker is recommended only for women 35. No, it's a universal screening for everyone. Assign separate risks for ultrasound. So we've seen so many times. Sonography kiya, risk आया 1 in 343. Double marker kiya, risk आया 1 in 8,000. Dono combine kiya, risk आया 1 in 3. The lady, the couple is getting 8 numbers in front of her, which is so confusing for not just the couple, but also the obstetrician. The rule and the standard of care is combined first trimester screening. It is not to assign separate risks on your ultrasound and your labs. So please refrain from doing that. If double marker is low risk, do a quadruple marker. No, double marker is a better screening test than quadruple marker. So once you've done a screening test, if you want to do something next, do something better and not something less than that. Thank you so much for the patient hearing, and sorry if I overshot the time.
Thank you, Pooja ma'am, for an excellent talk and clearing the basics of how to interpret this test. So there was a question on the chat box. I think you've answered that all. Dr. Sham Kulkarni has asked whether you need to give details of fresh embryo transfer, donor use, donor X. So you have, I think, answered that question correctly. So
just for example, sir, if I could interrupt, I'm just giving an example like Lilacs or the Estraya software that you use. Once you write that yes, this is an IVF or an ART conception, immediately the next pop-up the pop-box comes up which asks you, is it an IVF or is it an ICSI? Whatever it is it of a self egg or a donor? Is it a fresh or is it frozen? They ask you all these questions, and only once you answer them all, they will give you the moms. So they will just not give you the multiples of medians unless you answer all these questions.
any other question, any of the co-hosts, or is there any question on the chat box, MOC, if you can see?
Yes, ma'am. One question is there. If risk of ICG MOM is 2.6, what significance does it have?
Yeah, so this is a common scenario. The first thing is you rule out that it is a multi-fetal gestation because usually 2 to 3 moms is very commonly seen in twins. Secondly, if it is a singleton, Down syndrome risk is low. More than 2.5 moms of beta HCG is associated with a slightly higher risk of fetal growth restriction and placental abnormalities later in pregnancy, but it is not significant as a low PAPA. So there are excellent SOGS guidelines that tell us about this. More than 2.5 moms, higher risk of fetal growth restriction.
One question I would like to ask is, we have this intermediate risk criteria in the combined test, NT plus double marker for the Downs. Now, suppose you get a test in quadruple marker, which says the Downs risk is 1 in 600 and 700. So is there any concept of intermediate risk in quadruple markers?
Not by accredited labs, sir. Those who give it, change your lab.
Okay.
So basically, when you get an intermediate risk, it's not just that those two words you read. You go back and see, why is the risk intermediate? Why is she not low risk? Is her age 40 years? Are the bloods not good? Is the NT high? Because depending on what element on the test has given her an intermediate risk, you are going to decide your next test. If her NT is 3.5 millimeters, and that's why she has an intermediate risk, you would not want to go in for an NIPT like Sita ma'am is going to tell us now, because high NT is associated with 10,000 more things rather than Downs. So look at why she is intermediate risk, because that will help you plan further.
Thank you. Thank you.
Thank you, sir.
Thank you, ma'am, for such a nice presentation. Many of our doubts are cleared. Thank you. Thank you once more. So the next talk is Dr. Sita Ramamurthy ma'am and Dr. Hari Radhakrishnan. Dr. Sita Ramamurthy ma'am, she is a consultant fetal medicine at Apollo Hospital, Kolkata, Joint Clinical Secretary of Bengal. And Dr. Hari Radhakrishnan, he joined NIPT Genetics in 2015 to lead the marketing and business development and efforts of NIPT Genetics. So over to you, ma'am and sir.
Yeah, can you hear me now?
Yes, ma'am.
Thank you. Thank you so much. So at the outset, first of all, thank you, Pooja, for an excellent overview of that annulates and to set the tone for my talk on NIPS. And thank you, Navi Mumbai Society, Dr. Rahul, Dr. Sachin, and to give me this opportunity. I feel a bit nostalgic because I'm not far. My alma mater is not very far from Navi Mumbai, basically from Sion Hospital. So it does bring me back old memories. So thank you. And today I am going to be talking about NIPS or NIPT as we call it. And I will be speaking about what the possibilities we have with this screening test in our armamentarium. And then Mr. Hari Krishnan will also talk about what are the advancements that we can have with this. So that's me for you, and thank you for this opportunity. So just before we start, we need to understand that when we look at chromosomal abnormalities, you can have abnormalities in number, and the most common is obviously, as we see in the trisomy 21, and then the abnormalities of structure, which sometimes we forget. And of course, if there are unbalanced, that is, if they have deletions, duplications, they can have implications which can go unnoticed. So that's the important setting we need to know of, and just not concentrate on Down syndrome. Though because Down syndrome is also the most common cause of intellectual disability. And in India, the prevalence is reported to be around 1 in 1230 to around 1400. And we should be aware that it increases with age. We know that, but it also decreases with gestational age. And 70% of women, babies that are Downs are born to women who are less than 35 years of age. And that is why the importance of universal screening. And unfortunately, well, I would say that Down syndrome still remains the main focus of screening when we forget the other important problems of other chromosomal abnormalities and other problems that can affect the mother in a major way. Now, as we've seen, this is the timeline, for a prenatal screening. There has been, lot has been done from many ages, from the 70s, where we started for karyotyping only for age. We came along the triple screening and then the rapid aneuploidy detection. And finally, with the combined test in the 21st century, with the NIPT changing the paradigm and making a paradigm shift in our prenatal screening. So as we've seen, there are different models. I'm not going into the details. We have our combined first trimester screening. We don't recommend the age, but the combined screening where we use the PAPE and NT with the HCG, that will give you a sensitivity of about 86 to 90%. When you add additional markers like ductus venosus and tricuspid regurgitation, all for a false positive rate of 5%, it increased the detection rate. And of course, as Pooja said, triple set should be thrown out of the window, should not be used anymore. So why are we evolving with our screening test? Because we need to increase the detection rate and then subsequently reduce the false positive rate. And of course, however low the risk of invasive testing is, which the women are still afraid of having an invasive testing because of the small risk of miscarriage. And of course, there can be sometimes with unreliable serum screening and NT assessment if proper accredited tests are not being done. And of course, whatever we do have to be cost effective for the entire population. So does NIPS meet all the criteria? So what is NIPS? Basically, it is a non-invasive prenatal screening test. The most important word here is screening. That's why I changed the thing to NIPT to NIPS, which is used interchangeably. But it's basically a quantitative analysis by measuring the cell-free fetal DNA in the maternal plasma. And that's how you examine the fetal genetic material in a sample of maternal blood. So what happens is there are DNA fragments that are found floating in the blood of all individuals. And in every pregnant woman, you have some DNA from her own, fragments from her own DNA, and some fragments of the placental DNA, which is basically derived from the outer cytotrophoblast rather than the inner mesenchymal layer. So it is very important because it is not actually giving the genotype of the fetus. So what is cell-free fetal DNA? It is the DNA of placental origin. It is cell-free and it is found circulating in maternal blood. And it is basically fragmented when these placental macroarticles are shed in the maternal circulation. And so the difference in sizes between the maternal and fetal DNA can allow this DNA to be distinguished from each other. And they can be seen anytime from 10 weeks onwards. It increases by about 0.1% per week and increases by 1% per week after 20 weeks. So it is present from after 5 to 7 weeks, but usually detected from 9 to 10 weeks. And the best part of it is absolute no memory. That is, it is cleared within hours of placental removal. So once the mother delivers, this cell-free fetal DNA is out of her circulation, and then there is no remnant of that left. So every time she has a new pregnancy, the new cell-free fetal DNA will be found. And this shows specificity for placental gene expression and is not altered by race parity. So it's a very reliable source of prenatal fetal DNA-based studies, and obviously it's non-invasive. And we do know that it has been pursued for more than 4 decades, and only in 1997, Loy et al. Had found the presence of fetal DNA in maternal plasma and serum, and since then, a lot of work has been going on. And so as we can see, it can be done on the maternal blood anytime after 10 weeks. You need only about 20 ml of maternal blood. And it was basically started off, and it's still very good, as we would see, for the common trisomies like 21, 13, 18. And of course, if it does, it actually was started off to guide the management of women who are Rh negative, but it's still not being done. But if that could be done, would save these Rh negative mothers a lot of screening, monitoring as we do, but that's a different thing we're not discussing here. And of course, fetal sex determination in cases of pregnancies of high risk of sex-linked genetic risk. Now, this NIPS, the technology that it uses is usually the next generation sequencing and bioinformatics to basically analyze and interrogate the DNA fragments that have been extracted from maternal samples. And so the most two common methods are the massive parallel sequencing, where you can see that the blood contains both maternal and fetal DNA, and then you compare, and if there is any excessive of the cell-free fetal DNA, assuming that the mother is normal, you conclude, or you come to excuse me, can you please mute yourself, that this is from the fetus, and go ahead accordingly. So this is the massive parallel sequencing, where you evaluate the quantitative changes in the proportion of each chromosome derived component, and any extra fragments that are derived is assumed to be from the fetal, which is affected possibly with the common trisomies. The other technology is the SNP-based single nucleotide polymorphism, where you combine the risk from individual targeted single nucleotide polymorphisms, and the results indicate an increased or missing amount of chromosomes by detecting the shifts in the SNP patterns. And the important advantage of this is that it can be used in twins. And of course, because it goes by the genomic value, it cannot be used in donor egg or surrogates if the mother is a carrier of a mutation or she's an organ transplant recipient. So the most important thing which determines the result of this cell-free fetal DNA is the fetal fraction. And so that is why it is important to look at the report, like what it is saying, because and the fetal fraction will determine whether this test is done accurately or not. And what is fetal fraction? It is the percentage of fetal DNA found in the maternal blood, and which increases with gestational age. And this fetal fraction is critical to the success of NIPS. So anything less than 4 is actually too low to report, and ideally you should have more than 8, but between sort of 4 to 8% is acceptable, and that would be ideal. So when you put your cell-free fetal DNA in your box of other screening methods, the efficiency goes up to almost more than 99%. But having said that, it performs extremely well, and very important to know for the common trisomies. Like for trisomy 21, the detection rate is almost 99.7%. It is not 100%, and that is why it is still a screening test. And this comes with a false positive rate of 0.04%. So similarly, in singletons, it performs very well for the common trisomies. Even for twins, as we've heard, it performs very well. So it can be offered for twins. Of course, you have to remember that in dizygotic, the lower fetal fraction is used, and monozygous, it is as effective as singletons. So with twins, as we've seen, that it is, it is very encouraging. There is a lower fetal fraction, which you have to remember, and that's why there can be a higher failure rate. And of course, if it is screen positive, she needs a double invasive testing. Again, a word on vanishing twin, it can be false positive because of the aneuploidic twin, which has caused the fetal loss, and that's why it's come as false positive. If you want to do it, you should do it almost 6 to 8 weeks after the if the vanishing twin is there, it has to be preferably avoided. So if you compare the conventional screening with cell-free fetal DNA, of course, the sensitivity depends on the type of test you use in conventional screening. But in cell-free DNA, it is very sensitive and specific, with a very low false positive rate. But the important thing to remember with the cell-free fetal DNA is about the positive predictive value. So in low-risk population, where the incidence of a particular disease is very low, the positive predictive value decreases. But in a high-risk population, it increases to 90% with a very high negative predictive value. And obviously, with a conventional screening, the main advantages that you can see for other conditions, where in cell-free DNA, as of now, it is very sensitive for the common aneuploidies like 21, 18, and 13. So the advantages would be it's non-invasive, there is no added risk of miscarriage, with a very highly sensitive for the common trisomies, as we have seen, with a very high negative predictive value, which means that if the test is negative, it's very, very reassuring that the baby is not affected with trisomy. So again, the bottom line comes to as to how well we counsel this woman before she embarks on any test for that matter, be it a double marker or be it an ultrasound even, or when she embarks on an NIPS. And this comes from the obstetrician because they are the ones who deal with the report. So it is important to have a proper pre-test counseling. So adequate information regarding what are you screening, what is the risk, whether when she walks in, there is a risk that is an a priori risk, when she has a particular test that changes the risk, so that the revised risk, and what are the benefits and limitations of the whatever screening or diagnostic test is available. Again, very important to reiterate that it is only a screening test and it is best validated for trisomy 18 and 13 and will not identify all babies with chromosomal abnormalities. And of course, again, important to remember that the younger patients who come up with these results have a higher risk of fetuses with micro abnormalities than 21. So again, we have to think beyond trisomies. And a screen positive test means, and a positive test will have to be followed by a direct invasive test, because it is a screening test, and a positive test does not necessarily mean that the pregnancy is affected. Sadly, we still see patients who terminate on the basis of an NIPT wrongly done, and a normal pregnancy is lost there. And of course, you can have incidental findings on this NIPS, which is which have to be counseled equally. So not to forget how beautifully we've seen what we can achieve a lot from the first trimester scan, starting from dating, viability, chorionicity, which forms the mainstay of treatment in our multiples, structural fetal problems, which can detect, and a lot more things which can be detected, which is more common and can affect the mother more severely. So just to go for a few cases, that this lady has a previous cesarean spontaneous conception. She had this risk, which was, sort of intermediate, or I would call it high risk only. But having counseled the mother, she had a risk of trisomy 21 of 102. And she went in for an NIPT and came in as low risk. Again, as it's important to see that what is causing the high risk, whether it is the NT per se, or if it is the PAP-A or the free beta HCG, as Pooja said, because usually PAP-A reflects the placental problems and free beta HCG would reflect the fetal problems. And if the NT is obviously abnormal, we wouldn't go for another screening test. So again, look at the analytes and see what is causing the increased risk, intermediate or high, and then deal accordingly. Another case, this was an IVF conception. She had a risk of 1 in 50. Again, NIPT would not have been recommended, but she did go in, and this came in as high risk, and rightly so. She needed an invasive testing, which was done and confirmed a trisomy 21, which she then terminated. So the lesson to learn is it is a screening test. It's not a diagnostic test. Positive result has to be confirmed by invasive testing, because a low risk does not exclude trisomy and a high risk is not diagnostic. And you have to know when to perform the test rather than doing it as a breakaway from invasive testing. So when can you have false positives? When there is a confined placental mosaicism, as we've seen, when there is a demised twin with maternal obesity, a very, very common problem now, because they have a low fetal fraction, you can have false positives. So again, very important to counsel these women that this test might be falsely positive and we might have to do something else about it. And then false negativities, obviously, false negative results are very low, but sometimes because of maternal copy number variants or technical issues, you can have false negatives. What about sometimes there are non-issues? Again, this was one case where everything else was fine, but there was sex chromosome aneuploidies. And then we didn't know what to do. Well, we did counsel, there was nothing major is going to happen. And she continued the pregnancy and the baby was fine. So it is again important to counsel them that there could be sex chromosomal aneuploidies that could be detected. And then about the failed result, because there was not enough fetal DNA because of a small placental mass, which could mean that the baby is actually aneuploidic. So a test failure could be because of a low fetal fraction, a laboratory failure, maternal drug exposure to low molecular weight heparin. A lot of our IVF women are exposed to this. So it's again important to time the test as far as possible from the last injection of a fetus. These small things make a lot of difference to what your report will come, and that will guide accordingly what we need to do further. So the Fetal Medicine Foundation has come up with what we should be doing ideally with a failed cell-free fetal DNA. If there is abnormal findings, of course, we do a detailed ultrasound, and if there is abnormal findings, you have to consider an invasive test. But if there is no abnormal findings, you could repeat the cell-free DNA, and if it's normal, you don't need to really worry about it. But if there is failed, it's again failed, and you go back to look at the risk of the previous prior risk for trisomy and decide accordingly as to what you would do. Now, once the test comes, it's also important to do a post-test counseling. So whatever the results have to be communicated in a timely fashion. And then if there is screen positive, as I've said earlier, has to be confirmed with an invasive testing, either with CVS or amnio. But because CVS assesses placental tissue and there is a risk of confined placental mosaicism, a follow-up with amniocentesis may be required. And needless to say that when there is if the cell-free fetal DNA is normal, the residual risk would still be around 2% for a chromosomal anomaly. So the implications in practice for our country, especially with everything put, I don't think we should still recommend it as a primary screening in India without anything else. It could be a secondary screening method when it is found to be high risk on conventional screening, or there is a history of prior trisomy 21. If there is advanced maternal age, when you know that the conventional screening may not perform very well, again, looking only for trisomy 21. And if there is a parental balance translocation with increased risk of trisomy 21. Again, important to note that you shouldn't be doing it as late as 20 weeks, because if the test is done after 17 to 18 weeks, if it comes positive, you still need to do an invasive testing. Time is lost there. So everything has to be decided when you actually advise for the test. So again, this is again the FMF protocol where they have looked for a contingent screening, which Pooja has said earlier, that if it's low risk, you don't do anything. There is an intermediate risk, depending on where your cutoffs are. If it is positive, you would do an invasive, or if it's you do a cell-free fetal DNA, and if it's negative, you do an ultrasound. Similarly, for Indian scenario, this has also been recommended as to you do the double marker with the nuchal translucency. If the high risk is more than 1 in 100, then you advise an invasive testing. And if it's less than 1 in 1,000, which should be classified as low risk, then you reassure. But going by what our lab reports say, I think we would still go by the 250 risk and put it between 250 to 1,000 would be the cutoff for intermediate risk. So again, the suggested protocol for trisomy 21 and the Indian scenario, just an algorithm here, and then you can decide whether you want an NIPS here or you have to go ahead with an invasive testing. Another important thing to remember is when not to do this test. Very, very important, because if there are any structural defects in the fetus, even for that matter, an NT more than the 95th centile, any NT that is abnormal, any defect, any structural defect in the fetus, you should not be doing a screening test. Sorry. You need to do an invasive testing to confirm what this baby is having, and if there are any karyotypic aberrations in the parents. So there are still concerns about NIPS that if it's, you can have misdiagnosis of atypical chromosomal aberrations in the intermediate and high risk group when NIPT is offered for common trisomies instead of invasive diagnosis. And if offered as first line, genetic conditions other than the common trisomies and fetal structural anomalies may be missed, or diagnosis can be delayed. And in fact, a recent study showed that management would be changed in almost 10% of cases when ultrasound was done before blood for NIPT was drawn. So it is important to remember that the first trimester screening has to be done before you can offer the NIPT or NIPS. Now, what about soft markers? Now, can we ignore this second trimester soft markers in the women with low risk? And yes, because they don't have any value after a low risk. So the so-called genetic sonogram, which looks for soft markers, should not be performed in a woman with a normal NIPT result due to its high false positive rate and poor positive predictive value. So this is a consensus statement about significance of soft markers after you have a normal NIPT. So just coming up with the recent guidelines that have come up by the ACOG and SFM, Society of Maternal Fetal Medicine, that screening and diagnostic testing should be offered to all women. Cell-free DNA appears to be the most accurate screening test for trisomy 21, which compromises about 50%, but it does not screen for all chromosomal conditions. So diagnostic confirmation is recommended for women with abnormal cell-free DNA results, and irreversible decisions should not be taken based solely on the cell-free DNA results. Genetic counseling services are important, and so you need to make sure that these people are counseled adequately pre and post testing. Any test failure should be informed that if there is a test failure, which means that there is a smaller placenta, and that's why there is a higher chance of a baby being aneuploidy. And again, so offer them a genetic counseling and then repeat the screening depending on what they would like to it. But if the ultrasound is anomalous, or if there is a later gestational age where you can't have options, then the repeat screening is not advisable. For microdeletions, I'll move on. I will leave it to our next speaker. But as of now, they can have high sensitivity, but because of their very low positive predictive value, they are not validated yet. Similarly, for the single gene disorders, it is clinically available, currently not recommended. So the CanIPS actually globally, it is available in over 60 countries. Netherlands offers to all pregnant women. UK does it by the contingent screening, and Europe also by the contingent screening, depending on the cutoffs, which vary from 1 in 50 to 1 in 1,000. We have Indian data as well, where it came from from Dr. Verma's group, and where they did a 10-center study using SNPs, and it showed a sensitivity of 100% for the common trisomies with an average fetal fraction of 8.4%. And they did do this study where the Indians' perspective is, because we still have need for better awareness and knowledge, cost issues, which will possibly come down, and sometimes with no result or delay in result when the patients have poor access, with lack of national consensus or screening program, and with very poor communication skills, we still need to put it in perspective before we offer it to all our pregnant women. So the key messages would be that all women should be offered an aneuploidy screening, whatever you have and what is available and what is suitable and acceptable to the couple. No test is superior in all circumstances. A thorough pre-test and post-test counseling is required. Obviously, one doesn't fit all. So one screening model, you have to use one model that should be used for that couple. You can't keep changing. Use one the first trimester and then the second trimester. Obviously, the first trimester scan is mandatory because it has much, much more to offer if done properly. Look at the analytes, as I said, and think beyond trisomies. NIPS still remains a screening test, excellent for Down syndrome, but not ideal as a primary screening tool because we have a heterogeneous population, so should always be combined with a skilled ultrasound examination. And the most recent also said that the comprehensive approach is to combine an ultrasound with an NIPT would give the most sort of acceptable screening method. Counseling doesn't tell us yet about other chromosomes and genetic disorders. Of course, we need to remember it's market driven. So you have to remember what is suitable for the couple, what is its cost effectiveness with PCP and AT issues. Screen positives have to check that it is influenced by the patient's a priori risk, what is causing the screen positive, and then to follow it up with a diagnostic test with cytogenetic analysis. There are ethical and social values because you sort of genetically determine this fetus, in which way it's going. We don't know, about certain non-issues that might come up. So it is important to remember that the test has to be done for the right indication on the right patient by the right doctor, the right time, with the right follow-up. Thank you so much for your patient hearing. I'll leave it to Mr. Hari Krishnan for the rest. Thank you.
Thank you so much, ma'am, for such an informative and crisp presentation. So now we next to the other presentation by Dr. Hari Radhakrishnan. Hari, sir.
Yeah, just 1 second. Can you see my screen?
No, sir, not now.
Okay. I'm having a small technical problem. Please give me 1 second to restart Zoom.
By the time sir logs in again, if I can ask a question to Dr. Sita. Sita ma'am?
I'll unmute myself, yes.
How early can we advise in a NIPT?
As I said, from 10 weeks onwards, but you can. But ideally, if you do the first trimester scan between in the 12 to 13 weeks and then offer, that would be ideal because you have the ultrasound scan. You shouldn't be doing an IPT and then finding that the baby has a major anomaly which was not detected. So ideally, ultrasound first, but technically it can be done anytime from 10 weeks onwards.
And how late can we offer this test in a pregnancy?
It can be done till term. So, that's not an issue. But what are we going to do about it? That is an issue.
I understand. But recently I had a case who was undiagnosed duodenal atresia, which was diagnosed late in trimester. though her aneuploidy screening was negative done in first trimester, still we had a doubt of ruling out aneuploidy. So in such case, can be advised.
This is a major structural anomaly. No way does a screening test come here. Duodenal atresia is a major anomaly. You have to do an invasive test to rule out, from aneuploidy there. So a screening test will not be done whenever detected, early or late.
I think sir is ready.
Limit of gestational age for validation of such test of
Sorry, I didn't get that. Sorry.
Any distal limit of gestational age to detect or find out aneuploidy.
As I said, it's mainly a screening test. So, if it comes positive, there is no limit as such, but if it comes positive, you have to follow it up with invasive testing. So the later you do it, you're going to subject the mother to more anxiety and more, testing. If you have time in hand, that is that, window between we get the first trimester double marker test, and then you're waiting for an amnio, and, she wants, and depending on what the risk is, of course, as I said, if there's a defect found or an NT is very high, we wouldn't advise. But you have a window and the mother is keen, knowing all the risks or the limitations, then you can do it. But the later you do it, you're not actually gaining much by that test. Of course, if it comes negative, the negative predictive value is very good, but there's always a small chance it is, it can be positive, and you have to go in for an invasive testing. I think, yeah.
I think Hari sir is ready. So
ready, yeah.
Hari sir, you're sorry, maybe unmute करायचं त्यांना सरांना.
I hope everybody can hear me. Thank you. Thank you for the invitation. Good morning to everyone. And I wanted to introduce to you a little bit about the different technologies that we have in NIPT and about how we are doing NIPT differently at NIPT Genetics that we are currently offering through Lilac to all the clinicians here in India. I'm Hari. I'm actually coming to you live from Cyprus, which is, it's 9 o'clock in the morning for me. So hello to everyone there in Navi Mumbai. So as Dr. Sita pointed out, NIPT is a fairly recent innovation, and it was with Dr. Lowe's discovery of cell-free DNA in the blood in '97. But then there had to be analytical method, which was the next generation sequencing, which was quite expensive at that time, coming in with the same time as the discovery. So the first generation NIPTs actually since '97, it was in 2010 that the first generation NIPTs were actually commercially available. And these were all based on whole genome sequencing, where the cell-free DNA is extracted from the maternal plasma, and then it goes through a process called library preparation, where it is adapted to go into the sequencing, into the next generation sequencing machine. We do the sequencing, and then we do an analysis. And the analysis is fairly straightforward also, like Dr. Sita pointed out. You're looking at what is a normal reference chromosome, and you're looking at the other chromosome, whether the level is, compared to the reference chromosome, is it higher or lower? And there's a little bit of a statistical noise there. So it's done as what is called a normalized chromosome value. If the normalized chromosome value is more than 3, then it's clearly much higher than the reference. But if the normalized chromosome value is close to 0, then it's a negative. But there is a little bit of an inconclusive range where the statistics comes into play. And the reason this comes into play is because the whole genome sequencing methods, they are low read depth. You don't read the entire genome, or you're trying to read all the chromosomes in the genome. So you're not focusing on the chromosomes that you're of interest to you. So you sort of spread all your reading over the entire genome. And you cannot measure the fetal fraction in an accurate way because it has a very low read depth. Poor sensitivity and specificity compared to the newer technologies, but much higher than the original serum screening that was used for detecting aneuploidies. But one great advantage of the whole genome method is that we are actually looking at the original cell-free DNA fragments that is coming from the maternal blood. So to address this issue of lower sensitivity and specificity came out the second generation of non-invasive prenatal tests, which, in about 2013 or so, which was instead of looking at all the chromosomes, we are primarily interested in the 21st, 13, and 18 chromosomes, and to a certain extent, the XY chromosomes. So we just focus all our sequencing efforts and all our energy into looking at only those chromosomes. So after the cell-free DNA is extracted from the maternal plasma, it goes through a targeted library preparation where they use multiplex PCR. We are all experts in PCR now, so I'm not going to belabor that. So they use multiplex PCR to amplify certain regions of the chromosomes of interest. So you only target the 5 chromosomes that are of interest. We amplify those regions using PCR, and then we look at those regions in a lot of depth. So much higher read depth because we are focusing our efforts, and we can use the targeting to catch regions where there are single nucleotide polymorphisms to measure the fetal fraction by comparing the ratios of single nucleotide polymorphisms, and a much higher sensitivity and specificity. But unfortunately, now we're no longer looking at the original cell-free DNA fragments. We are actually looking at clones of regions of interest. So you lose some fragment size information. We cannot get rid of the PCR errors, and there's a limit to what we can do with multiplex PCR. And this is reflected in several independent studies. So several independent studies show that there's a very high sensitivity and specificity, but about 90% of the positives are true positives. There is 1 out of 10 true T21 positives is a false positive, and the true positive rate for trisomy 18 and 13 is actually lower too. And other independent studies have looked at what are the reasons for this promise of NIPT not being reached. And there are basically of three causes. The first one is of causes which are biological in nature, like copy number variants. So mother may have a maternal copy number variant where she may have more copies of certain regions or less than 2 copies. And this can mask a potential trisomy in the kid or show it as a false positive if she has more copies. And this can affect both SNP-based test and whole genome read depth-based test. The second cause is inaccurate or poor fetal fraction measurement, which is basically a technological issue. So if they are not able to measure the SNPs, or if the measurement method is inaccurate, then the fetal fraction measurement is poor, and the fetal fraction measurement is very critical in feeding into the statistical algorithms to determine whether it's a true positive or not. So if you have technical issues with your fetal fraction measurement, then your sensitivity and specificity of the test is poor. And the third is technical reasons, but they are coming from biological origin. So regions which have a high concentration of the G and C bases, these are difficult to amplify, difficult to sequence. You may have regions which have complex genomic architecture, and these can cause sequencing biases and amplification biases. You can also have regions which are very similar to other regions in the genome, so you can end up with mapping biases. So these are technical problems which you can get rid of to a certain extent using bioinformatics, but at the end of the day, you can only diminish it, cannot actually solve the problem. So we considered all of these things when we developed our technology. It is also a targeted technology because it provides higher sensitivity and specificity. But instead of using multiplex PCR, we use in-solution hybridization. And the advantage is that we are able to actually look at the original cell-free DNA fragments that we collect from the maternal blood. So we can use this to mitigate PCR errors and to remove PCR duplicates. But it also gives us the very, very high read depth and the high sensitivity and specificity and the fetal fraction. And because we have access to the original cell-free DNA fragments, we are able to look at things in a different way. We can look at the read depth counting information, just like a whole genome sequencing based test would do. But on top of that, we can also look at fragment characteristics like fragment length, which as Dr. Sita pointed out, smaller fragments come from the fetus. So we can look at these fragment characteristics also, and we can do these orthogonal analysis, which we then combine to get a higher sensitivity and specificity. This is a short picture of how the workflow happens. We use the synthetic DNA fragments called tags, and these tags are we activate them by connecting them, by coupling them to magnetic beads. And when we take the cell-free DNA library that's coming from the maternal plasma, only the homologous DNA fragments, which are homologous to the tags, they attach to the tags. Then we separate the beads magnetically, and then we separate the cell-free DNA fragments to get this enriched library. When we put it in the sequencer, you get a picture which is similar to what's on the right. So you get this very, very high read depth of the regions of interest, and the other regions that we are not interested in, we barely see any DNA. So because of this high read depth, we are able to get strong statistical performance and analytical performance. So tags themselves, we design them to capture DNA from the regions of interest. So if we are looking at aneuploidy, for example, trisomy 21, what we do is we design tags for the entire chromosomal region. But if we want to look at 22q, if we want to look at DeGeorge, then what we do is we design tags which are specifically targeted to that region of the 22nd chromosome. We can also look at point mutations, in which case what we do is we overlap tags to make sure that we have a lot of enrichment in that mutation hotspot. So if there is a point mutation that's happening there, we can detect it very clearly. Veracity, we validated it in 2016, and it allows aneuploidy detection even in complex pregnancies like twins, vanishing twins, and gamete donations and surrogacies. But it's targeted specifically for the 3 main trisomies, sex chromosome aneuploidies, and a few selected microdeletions. It has 4 specific technical advantages, and I'll go over them very, very quickly now. So the first thing is that it's a targeted genomic analysis, which means that we specifically select regions which give us a lot of information, which have GC balance, so we don't have to worry about amplification and sequencing biases. And we get rid of regions like where there are known copy number variants or there are repetitive elements which can reduce the accuracy of the test. We use a lot of tags, a high number of tags. We make sure we read them to a very, very high read depth, and then we use multiple bioinformatic analysis on the data that we collect. Because we have very high read depth, we can use the SNP information to measure fetal fraction, but also the high read depth makes sure that it gives us a very, very high signal to noise ratio. The fetal fraction measurement is done using SNPs, not fragment characteristic information like it's done in whole genome sequencing. So it's actually an objective measurement, and we are able to get repeatable results from this method. And fetal fraction is actually extremely important to the accuracy of results. We consider accurate fetal fraction measurement to be a shield that protects us against false negative results. So if the fetal fraction is low, especially around the 4% region, which is what is recommended by ACMG and several other societies, then if the fetal fraction is lower than 4%, there is a chance that the statistical algorithm will call a positive as a negative, and that is going to be bad. False negatives is something that we actively want to avoid. That is why we tune all the algorithms to, false positives, we can always go in for a diagnostic confirmation, but false negatives, we should try to avoid at all times. And that is why fetal fraction is extremely important. And ACMG recommends about a lower limit of about 4% fetal fraction, which happens in the 10th week of gestation, and that labs should repeat and monitor their fetal fraction measurements, and also all labs should report the fetal fraction. We also have a proprietary bioinformatics algorithm, like I said, because we have access to read depth-based information, which is basically how many fragments we have got from each region, but we also have fragment characteristics. We can see whether the fragment is longer, it's shorter, and we use this information in parallel analysis, and then we combine the results. And this helps us to get rid of some other causes of false results, such as maternal mosaicism. So we did several validation studies, which the first one was published in Clinical Chemistry. And then we got about 100 samples from Professor Nicolaides, which we again reported back to him with excellent performance. And then we have also recently published a clinical performance study, which used over 10,000 samples. And I want to very quickly point out here that while we have good performance in 21 and 18, reporting 100% positive predictive value, trisomy 13 and monosomy X, the positive predictive value is about 71% and 57%. And there are biological reasons here that we cannot overcome at all, no matter how hard we try. And at the end of the day, the biological reason is we are looking at placental DNA and not what is coming from the fetus. And we always have to be aware of this. And the positive predictive value is very important to consider, because that is a measure of, if you get a positive, how confident you are in conveying that message to the patient. So we have to remember that there's a high probability of confined placental mosaicism in trisomy 13 and monosomy X, and this is going to affect the positive predictive value of any NIPT when it comes to reporting these two conditions. But we have had other independent providers who use our test look at it, and they have been very happy with the performance of the test. This is a summary of different providers who have published a clinical performance study just like us, and we are very happy to report that the performance of our NIPT compared to the other technologies is much more superior. We can also do NIPT in twin pregnancies, and it's very important to consider here that when you have a dizygotic twin, a dichorionic twin, then the fetal fraction representation from each placenta is going to be different. And for an accurate aneuploidy detection, we have to sort of measure the fetal fraction contribution from each placenta independently. And whenever we do an analysis, we always have to look at the lower number of these two, because that if we just do a total fetal fraction and split it in half, then there is a chance that we are overestimating the fetal fraction. And especially in a discordant pregnancy, you may end up with a false negative result. Veracity, we are also, we are doing an ongoing study for microdeletions performance, because these are quite rare, the most common one being the DiGeorge syndrome. These are extremely difficult to analyze because they're very, very small and they happen in very complicated regions. But so far, we have been very happy with the performance of the test. But this is a study that's still ongoing, and hopefully we will have the results out in the very soon near future. Just want to leave you with a picture of where we can do different NIPTs. We can do sex chromosome aneuploidies only if it's not a multiple gestation, because sex chromosome aneuploidy can be masked by a normal fetus. In one fetus can be masked by a normal fetus. So we do not recommend sex chromosome aneuploidy detection. We cannot do sex chromosome aneuploidy detection in multiple gestations, but otherwise, even in the case of IVF surrogate or donor pregnancies, in singleton pregnancies, NIPT is an option. That's my talk, and I will give the floor back to the organizers.
Thank you, Hari sir, for your elaborate, detailed talk about this way of doing NIPT. So, request the MOC to take over, and Darshana, madam.
Yes.
Yeah.
Thank you, sir. Thank you for your nice presentation and informative talk. So the next is a panel discussion. The moderator is Dr. Sachin Nichite sir, and we are panelists. These are the panelists: Dr. Priya Deshpande ma'am, Dr. Pratibha Radhakrishnan ma'am, Dr. Sita Ramamurthy ma'am, and Dr. Hari Radhakrishnan. Over to you, sir, Sachin sir. Sachin sir.
Dr. Sachin, I think you need to unmute yourself.
Hello.
Yeah.
We can hear you, sir. Sachin, sir.
Okay. Good afternoon, everybody. We are back again with a panel. I welcome. I wish Dr. Anita should have been here, so it would have been more interesting. We don't need any introduction to any of our panelists because they have already spoken to us. Pratima Madam, our teacher, Dr. Sita from Kolkata, Dr. Hari, just now we heard him, Dr. Pooja, Dynamite of Fetal Medicine, our own Dr. Priya. Am I audible?
Yes, yes.
Okay, okay. I have tried to create this panel in a little different way. First of all, the first difference is I have put up some concepts, not a case-wise discussion. It's a concept in clinical practice and some scenarios in for sonologist also. The second difference is we don't want to interrupt our panelists. Already they are experts. We don't want to cut them. We want them to express. Is very important. I will say it is the most important question of the whole panel or the whole webinar itself. Performing an NT scan and double marker with these FMF standards, does it really matters for the outcome, or does it really matter for my own practice, or is it just a fad? Or is it just a propaganda going on? So I should start this question from Pratima Madam first. Yes, our teacher has to explain this. Ma'am, over to you.
Thank you. Thank you. I think, thank you very much. I think I am not a teacher. I'm a student myself. Always, still learning. I think your first talk, where you put in very elegantly that the NT scan, unless you do it correctly, you do it properly, it really does not translate into the high detection rates that we talk about. So I think first of all, you need, as an obstetrician, you need to decide what is it that you want to do for your patients. You want to give them good outcomes or optimize their outcomes. We cannot always be perfect, but optimize their outcomes. And if you have to go with optimization of outcomes, then you have to go through optimization of your scan and optimization of the blood test, because one without the other will spell a disaster, right? So it is absolutely an important thing that you must follow standards. Now, why FMF standards? I mean, FMF was the first one to come out with these kind of standards, and the whole world follows the FMF standards, and therefore FMF standards. It's as simple as that. It's got nothing to do with any personal organization or anything like that, because we know that NT was there before Kipros published his paper in 1990s, late 90s, and but he was the one who kind of standardized the whole thing, and there is no debate on what should there be. There's no debate as to whether we need to do it any other different way, right? So I think it is standard, and if your outcomes matter, then your NT scan to be done properly also matters. So I think that's it.
Sachin, I'll just interrupt here. I'll request Dr. Anuvich to join the panel. So if Dr. Anuvich is there.
Okay. Ma'am, are you there?
Yeah, she's there. I can see her videos off. So she can...
And if your NT scan is of good standard, but your double marker is not done on the accredited platform, and remember there are only 3 accredited platforms, and the reason why accreditation and the audit, everything is important, is because there is a continuous process of making sure that the standards are maintained both for the laboratories and for the people who are doing the NT scans regularly. Right? Every year we have to submit. 16 years I have submitted my audit. Every year I have to get myself you know, recertified in making sure that I'm doing the NT scan properly, not just by uploading 3 images, but also submitting my audit report. So there is a process which ensures quality. And if you really want to give that quality service, then you have to maintain the high standards.
I hand over the same question to Dr. Sita.
Yeah.
That clinically, practically, how really does it matter for the outcome or optimizing my own clinical practice as an obstetrician?
I think it matters in both ways. I know, as Dr. Pratima said, you are auditing yourself, your standards as well, and for the population in general, we want everyone to speak the same language. So if you're doing something, we want everybody to do it in the same way, report in the same way, so that we all know what we are talking about, and each one is not doing their own thing. So now that we have with the FMF standards as exactly how to go about it, what is the criteria. So when everybody does that in a particular way, we all know when something goes amiss or something is abnormal, we know what to look for and how to deal with it. So I think it matters for you as well as a practicing, fetal medicine specialist, as an obstetrician who sees the report as to whether it is done properly in the right way from the accredited center, from the proper lab, and then for the patient as well, because they know they go to different people and they're not hearing different confusing statements as what needs to be done further. So that is why we need something like this to guide us and to standardize it and, to speak the same language to all our patients. Thank you.
I asked this same question to Dr. Pooja in a little twist. That इतने साल से हम लोग एंटी करा रहे हैं, there is no double marker, आज तक तो कुछ नहीं हुआ, there is no Down syndrome detected, या अभी तक मेरे कान तक कुछ नहीं आया, my patient had suffered. What to do about these sentences?
I didn't get it, Sachin. So can you just repeat the question?
See, there is a scenario that in my own practice, like my own obstetric practice, मैंने इतने साल से एंटी कराया, डबल मार्कर नहीं कराया, not like preset first trimester screening, आज तक कुछ नहीं हुआ है. I have never heard of any patient going into any complication or Down syndrome or anything else.
With all due respect to everyone, you've not seen enough cases, because we know that the statistics indicate there are, problems going on. And I just want to add to what both madams have said before me. If you're doing something, do it right. The patients have the right to know what is the best available option. If they refuse to do it, take a refusal consent, but do it right.
Very true. Very true.
I just want to add in there, what you said is not completely
please.
true. We cannot sort of say that everything is like, it's done without any reason. Everything is done for a purpose. And if we look at it properly, we will there will be cases that will come out with it. And there are still litigation cases which we see, which is because it was not done properly or not acted upon properly, the patients are still being born. Obviously, it is a patient's decision, couple's decision, but we still have to inform them of what is available.
Okay, Priya, any comments?
I think all the messages are clear that we have to follow these rules, because a lot of research and study has gone into it. And of course, we have seen that detection rates have increased.
Okay, I move on to my next question. It's a very practical question, that so many labs are offering biochemical markers, double marker, quadruple marker, right from 400 rupees to 3,000 rupees, 2,500 rupees, whatever it is. So as a clinician, how shall I choose a lab? No, it is costly for patient if I go for different labs, higher labs, whatever say. But as a clinician, how should I research? What findings I should? What is the information I need to select the lab? I asked this question to Pooja.
Thank you, Sachin. So I had included one slide in my presentation which showed us that it is not just the software or the lab overall that is vaguely accredited. The standardization and the accreditation process happens at each step, from collecting the sample at the right time to collecting the sample for the right test, to the temperature control, the transport, the software, the reagents, the interpretation, and the translation into clinical practice. And you are right, with labs coming up in every nook and corner, we know we have to wisely choose. So choose a lab that just not boasts of an FMF software, because that's not the end of the story. But you need to make sure that all these aspects are looked into. Also, something new that is added on is an external audit system. For example, UK NICAS. Like we have Fetal Medicine Foundation, Pratima ma'am said that every year we submit our images and our whole audit data. Similarly, the labs are also answerable to into a body. Every year or after a particular interval, they need to get themselves externally audited. And these are the labs that will give you optimal results vis-a-vis a lab that is doing thyroid function tests and urine and sugar and all the routines. So you need to look at a dedicated lab who is abiding to all these criteria.
Can we make some clinical points that these 2, 3, 4 points, if I look into this lab or I experience this in this lab, I will choose that lab?
So yes, like I said, when you read the report, they mention the software they are using. Call up the lab and ask the reagents they are using. If I'm ordering a test and the lab is actually collecting a quadruple marker sample at 13 weeks, I will never send the patient back to that lab. So these are subtle things that you need to consider to finally fix. You may make mistakes initially, but eventually I think in a very short span of time, you'll realize what you want. So you are nobody to decide if the couple needs to spend 400 rupees on a double marker or 1400 rupees. Okay, so even an excellent lab will give you very economical, blood samples if you increase the number. And we've done it with Lilacs at Bharati Vidyapeeth. So it's almost a government organization, and we've slashed the rates to very minimal, in spite of being done at very accredited ways. Yes, Pratima ma'am.
I would just like to add on to that. I think if you're going to be following the FMF standards, there are only 3 analyzers. There are only 3 of them: the Roche platform, the Perkin-Elmer platform, and the and the Brahms scriptor. If you have anything other than these 3, then I don't think you should even give that lab a second look. Second very important thing, we talk so much about economics and this cost, this much amount, that much amount, and the labs are cutting each other's throats that if you do double marker, we'll give you NIPT free. If you do NIPT, we'll give you karyotype free. I mean, what are we? We are not sitting in a Bainganka market doing bargaining for Aloo Bank. We are not buying, we're not sitting in a vegetable market, honestly. I think we have to be clinical. We have to say that, okay, the lab which I can access easily, talk to the lab representative, and if they have made a mistake, I can say that you have made this mistake, correct it. The lab which will call me back when there is a high risk report, the lab which will act upon the clinician's request on working with the clinician rather than saying, okay, we will do like this only, you can never get through to the lab. I mean, these are the important things, and all this costs money. And the people who are sitting on the other end of the lab also are salaried people. They need to pay, and these reagents are not something that is generated in India. They have to come from outside. They have taxes that they have to pay. So what are we trying to negotiate here? If a child is born with Down syndrome, lifelong that couple will be paying for that child, right? So you need to decide what you're balancing. You're balancing a test which costs about 2,000 rupees versus a lifelong child that they have to look after with Down syndrome. And nobody absolutely will forgive you for that one child born with Down syndrome, irrespective of how many double marker, triple marker, quadruple, whatever markers you have done, right? So I think we have to practice safe. We have to practice for the society, for the well-being of the society. That's it. I mean, I'm not an economics person.
Thank you, ma'am. That was very nice.
Cost comes last. First comes our clinical decision.
I'll ask this question to Anu madam also, if she has joined us. Anu ma'am, are you there?
Yes, I'm there.
Yes, ma'am. Yes, ma'am.
No, I really agree with what Pratima has said. Can you hear?
Yeah, you're audible.
Yeah, but what I have in my personal practice, I have observed that the lab sometimes accepts NT which is not done by an accredited operator, and they will mark a disclaimer that NT not done by FMF operator, but still we are giving you the risks. So this is what I have a strong objection to. Here the lab has to be very clear. If we are following FMF guidelines, the lab has no business not following FMF guidelines.
Yeah. I think that's a lab that you will not choose. You will not send your next sample to that lab.
I have to
As
send
simple
because
as
there
that.
is no other lab.
We
I
can
put
find
my foot
labs.
down. No,
I mean,
Pratima, my
in a
foot
time
down.
where
I told them I will not, you better not do the test rather than give me the report.
Absolutely. You
Because
just give
we
a
cannot-
double marker, that's it, enough. Let's, a good, well-performed double marker is better than a bad NT included in the double marker.
Correct. And
And vice versa is true as
we
well.
had a practice of sending a sample image to the lab so that we are also sure the NT is done properly and the lab is also sure.
I think the clinicians should be making the decision and not the laboratories. That's very important.
Yeah, the approach has to be both the ways. If we are following, the lab also has to follow.
Has to follow, yeah.
So can I just chip in here? So it becomes the onus of the obstetrician when they're reading the report to look at the images, whether it was done properly, whether the lab has taken that into account, and then decide whether further testing will go to that lab or not.
Also, if I add it, if lab is not asking some counter questions like is it a twin pregnancy, is it dichorionic, is it monochorionic, is it a donor embryo, what is the age of the donor, then the lab is not doing justice to the test, I guess.
I would just
see
want to add
reports
a
of
few.
twins. Yeah, sorry, go on.
Yeah.
So I want to add a few clinical points because I've seen reporting which is done only on the double marker test. So when an obstetrician has advised for double marker test, they've given only the double marker test report. So that is something which, as a clinician, we should see that it can never and should not ever be interpreted alone. It has to be combined. So that is important. The lab should take history, take the report, and see who has done the scan, and then integrate it and then give a report. There have been instances where only the double marker test risk has shown something, but when we enter it into our software and then calculate the risk, it is not a high risk. So that is something which is important for a clinician to know, that how is it reported, is it combined or not. Secondly, if a clinician has ordered for a double marker test and the gestation has crossed 14 weeks, it's the lab's responsibility to not take the blood for double marker, and that's where the history taking from the lab side also is important. And I think as clinicians we can note these differences, and then we should accordingly choose our labs.
I think also we should first of all stop calling this as a double marker test. It's a combined test. That is the correct word.
Yes.
It's not a double marker test. Double marker is just a small component of the combined test. Now, combined test will include screening for chromosomal problems, will include screening for structural anomalies and detection of structural anomalies, and screening for preeclampsia. So the entire thing is a combined test. So that terminology we have to get used to and say double marker bhi kiya. No, the combined test kiya. Let's get the word, let's get the definition right.
See, the obstetrician has to keep her eyes open all the times. No, you can't hear me?
We can.
No, I meant eyes and ears open, both.
Ears open, correct. I'm just narrating one incident. We had 3 consecutive combined tests positive from the same lab in the same week. So the lab did not come back to us, surprised that how this has happened. We went to the lab, we checked all our reports, all our NTs were done properly. What boiled down to the fact was that the lab had taken the samples to some other processing center and the temperature changes had caused those effects. So this is another role of the obstetrician, because in my practice, I know after how many, what is the rate of, say, a positive test. So if you get 3 tests positive consecutively, that should keep the antennas up.
Pratima madam, as a teacher, I think you are expected to give your expert comment for each question, I think.
I am giving anyway. It's not expert. Everybody is an expert here. I'm very proud to see all of you. I'm very happy.
you, ma'am. Thank you. I move on to the question. Next question.
So I'm not a part of panel. I think let me just
Acha,
summarize the common obstetrician's view. What we need to be sure about, the NT should be done by a FMF accredited person. If not, then I think even the common obstetrician can develop that iconic image. If that image is there, then okay. Like then second part is of course lab. But the practice over here in Navi Mumbai is you order for first trimester screening, you go to any XYZ person, get a scan done, you send labs to any XYZ lab, and then patient comes to you with the report for first opinion, second opinion, and then you can't say and can't argue against your colleague saying that ये sonography का कोई मतलब नहीं है, ये lab standardized नहीं है. Now what next? You know? We all
Suchita, I would add online consultations also now.
True.
It's another disaster that is unfolding. You know, with the online consultations, although I have started doing, but it's tough. I must say. I think there is a nice way of
second opinion with all these results, and at the end you can't.
It's a nightmare.
You have to.
Yeah, no, it's not. See, I think first of all, we must understand when you're commenting things on the images and the laboratories, it's not against anybody, any personal person, anybody in person. In fact, I don't even know who's done the scan, who's done which laboratory, nothing. When they email the images, they email the thing. Most of the time, they're just like, images. And then the moment you see the image, you know whether, you should rely on that or no. Secondly, we giving second, third, fourth opinions, whatever, our obligation is towards the person who's sitting in front of us, that is the patient, because they have come to you in good faith and you have to tell them what is it in good faith. So there are many nice ways of saying it rather than pointing fingers at anybody. I said, okay, this image is not reliable enough, right? And, I cannot comment on this image or this laboratory. It's not about the laboratory. We also must understand prenatal tests are very, very specialized tests. It's not about big names. It's about doing that particular test correctly, right? So there are nice ways of putting it across and saying that it is not enough. So can we do something more to improvise on what you have already done, right? So I think how you speak. I think as doctors, unfortunately, in our medical colleges, we were not taught communication skills, right? We have to improve our communication skills and put it across gently to the, to the couple saying that, okay, this is not enough. Can we do more? Fortunately, I also add on this thing. Fortunately, you're only 12, 13 weeks and we have got a good 6 weeks to sort this out. In that time, let's do whatever NIPT that needs to be done or amniocentesis or CVS or whatever that needs to be done and, take another opinion. And most of the people, they come round to it and, and now, of course, we can find FMF certified people or, fetal medicine specialists across the country. And I'm not actually finding online consultations as difficult as I thought it would turn out to be. So I think unless we do that as well, we will not have those non-FMF or the ones who are rushing through the NT scan and sending it to any laboratory. They will not come in line. We all have to come in line together and walk together. And this is a story world across.
Madam,
it's got nothing to do with Navi Mumbai. It's in Bangalore. It's everywhere. All across. Even Kipros, it took him 15 years. It took him 15 years to convince the Royal College that NT screening has to be done for all, right? So, we are like chutumutus of, Kipros ka ke bhi nahi shuru hua hamara abhi tak. So it took him 15 years struggling in England to actually get to that point. So I think in 15, 20 years, we will get there. What I tell my patients is I'm doing this for my grandchildren, setting up standards. By that time, things will be sorted.
We move on to our next question. It is in the similar lines with the previous question, but I hand over this question to our NIPT experts, Dr. Sita and Dr. Hari. As a clinician, as an obstetrician, we don't know this difficult terminology like this platform, that platform, this affirmative or something, something, something. So how I choose my NIPT lab? It ranges from I think 7,000, 6,000, some labs giving to 20, 18,000. I don't know how to choose a lab.
Yeah. So basically,
Sita.
again, going in the same lines, it is important to choose a lab which is doing this test purely for that, with that in mind, like a pure genetic lab which is doing, rather than doing all the other tests together. So it is important to do that such a lab, uses a platform which is accredited, which is, like the most common platforms that we use is the Ion Torrent, which is not done here. It is sent to Singapore or Thailand. But the specific platforms that are accredited for this testing that has to be used, it mentions as we said, the report mentions the fetal fraction in the report, and so that we know that this lab is using the right way of performing the test. And secondly, because it also falls under the PCPNDT purview, it abides by all the PCPNDT laws, especially for our country. And of late we've seen that this test is being done even they go to the houses and collect the test, especially in this lockdown period. Again, these have to be discouraged, and that it has to be done in the proper lab with the proper PCPNDT settings, and which uses the proper platforms to perform the NIPT and report it correctly with the fetal fraction.
Dr. Hari, are you there?
Yes.
Yes, sir.
So
this is your cup of tea.
I agree with everything Dr. Sita said. Reporting the fetal fraction, how the fetal fraction is measured is, I think, the most important thing that we should look for, because, as I said, the fetal fraction is like a shield against false negatives. If you have a fetal fraction around 4%, or you should be very careful about the way the results are provided to you. Whereas if you have a fetal fraction which is like 10%, your confidence level is going to be much higher with the statistical score. So that is why the fetal fraction is to be important. Ideally, the lab would also report a positive predictive value. If it's not part of the report, they should have a publication which reports what is a positive predictive value, like a clinical performance study. Although everybody does things on very similar machines, the experience of each lab tends to be different, even if when people are using the similar reagents and similar technologies. So that's why even like a lab like Quest and a lab like Myriad, which are using the same technology, will publish independent clinical performance studies. So clinical performance studies to look at the positive predictive value, fetal fraction, and how it's reported, and other details, for example, which are coming from the clinicians, as you said, if it's a dichorionic pregnancy and how it is reported. These things should be part of the report, and that's what I think is the most important thing. Genetic tests are expensive, so you can not specifically with NIPT. Let me take a completely different example. So you can get a whole exome test for like about 8,000 to 10,000 rupees from what I understand in India. And you can also get a whole exome test, which is much, much more expensive. The difference is what is the depth of screening you're doing with the whole exome test, right? So that's why I'm taping. So those two tests will not have the same quality performance, because a genetic test, although you're doing exactly the same thing, reagents are expensive. So you are compromising somewhere to lower the cost, and you have to be always aware of what you're compromising. So cost, as Dr. Pratima put it, cost should be the last thing. Your clinical utility should be the first thing.
I have a question for Dr. Hari. Some of the newer techniques of NIPT do not require a fetal fraction to be reported. As a clinician, I have a problem with this, but how do we justify or unjustify this? Thank you.
You can always question this, Dr. Pratima, by asking, if you don't want fetal fraction, then why don't you do it at 6 weeks? Because there is an implicit assumption in the fetal fraction, right? So when somebody is doing a test, an NIPT at 10 weeks, the reason is because there's an implicit assumption that there is 4% fetal fraction there. But that implicit assumption assumes certain maternal weight, certain assuming a normal pregnancy. If you have a trisomy 13 or 18, where the placenta is smaller, that implicit assumption automatically fails. If the maternal weight it's a high BMI, that implicit assumption fails. Actually, if it's a South Asian woman, that implicit assumption automatically fails, because South Asian women tend to have lower fetal fraction than Caucasian women. So when people say we don't need a fetal fraction measurement, they're just saying that we are implicitly assuming that when you give me a sample at 10 weeks of gestation, that these assumptions are satisfied. So if you don't need a fetal fraction, why not do it at 6 weeks? Do it sooner. You cannot do it sooner because then your assumptions are failing. I hope that clarifies the point.
It's about the technique, apparently. Some different technique that they use.
It's not about the technique, because at the end of the day, we are all doing a statistical measurement. And the statistical measurement, as you know, if I'm getting 100 fragments and I know my fetal fraction is 4, then I know that 4 out of the 100 fragments, let's say I'm fudging the math a little bit here, 4 out of those 100 fragments are coming from the fetus, you know, and 96 fragments are coming from the mother. And for that to become a trisomy, the number goes from 4 to 6, right? If it is a 10% fetal fraction, it's 90% from the mother, 10% from the fetus, and the trisomy is going by from 10 to 15. So the fetal fraction plays a very important result in the confidence of the test. So no matter what the technique is, the statistical assumption is that the fetal fraction is hidden there somewhere. So we cannot escape that.
Thank you very much.
My next sub question is for Pratima madam.
Sachin, can I interrupt for a second?
Yes, ma'am.
There are some labs which are offering free amniocentesis if the NIPT comes positive. How this is economically viable, or is it just a fallback of their competence? How they manage this?
I can answer. It's basically a numbers game. If you are going to screen everybody in India, in the world, it's 1 in 1,000, 1 in 700 to 1 in 1,200 women are going to be positive if you screen everybody. So it's a numbers game. 1 out of 700, I can afford to do the amniocentesis. Even if it's 1 in 100, if you're just looking at high risk women, 1 in 250, it's all a numbers game there. It's nothing more than that.
It's business.
Yeah.
Good business. Right.
My sub question is for Pratima ma'am.
Yeah.
Ma'am, NIPS is just a screening test, just like quadruple or double marker. So we collect double marker, quadruple marker at home. Why not NIPT at home?
No,
or can
NIPT has, I think, for the simple reason, one is when you are collecting NIPT, we have to fill the F form because it has got a potential to detect the gender of the fetus. So to me, to collect an NIPT sample on the doctor's prescription is illegal both by the lab and the doctor will also get implicated. So the answer is no. I do not approve of it at all. It should be collected only from labs which are filling the F form, which have got the the appropriate legal permissions from the district appropriate authority, because it's an invasive test. It is invasive because you're digging up this thing. Whereas a double marker does not have the potential to detect sex. I mean, that's as simple difference in the two, right? Now the lab might be saying that we don't detect the sex and things like that, but how do you know that? As a clinician, you don't know your patients 24/7. Sorry. And a lot of patients do make a lot of backdoor things which we cannot rely on. So please don't do it. Don't allow.
And it has the potential to do it. You should not be doing it.
You should not do it. I mean, it's simple thing. It's just illegal, and don't do it.
Sachin, I would like to add here. Now, as Pratima madam has rightly pointed out, that this has a potential to detect the sex of the child. So wherever you are collecting the sample also has to be registered under PCPNDT, and they have to fill up the form F. Now suppose I am registered under PCPNDT, but I am registered for ultrasound. So if I am collecting for NIPT sample, there has to be an additional
NIPT in the form.
NIPT in my register. So I send my patient to the lab who has PCPNDT registration for doing NIPTs. So I don't collect it at my place itself also. So it is important that your place is recognized for NIPT. Only then you can collect the sample, and the labs which are accepting samples for NIPT should be accepting it from a place which is registered for PCPN. Otherwise, it is better to collect the samples at the lab itself.
Very true. I ask my next question to Dr. Pooja. We call it as 11 to 14 week scan. It's a wide range. Okay, so ideally, as an obstetrician, what time I should send patient for NT scan and why? I mean, what is the purpose behind that particular time? What you prefer? Is missing.
Most of the radiologists say 12 weeks is a better time to do an NT scan.
True, true. But I want the reasons from the experts.
Pooja is
Pooja is
asking to be
missing.
unmuted. She can't answer. Yeah.
Yeah, now I can unmute myself. Thank you. I wasn't able to unmute myself. So, Sachin, a very important question because this will help our obstetricians to refer the patient for NT scan at the right time. Now, actually speaking, the NT scan is allowed to be done when between 11 and 13 weeks and 6 days, which corresponds to 45 millimeters and 84 millimeters of crown rump length. But practically speaking, doing an NT scan at 11 weeks would give us a much technically easier way to measure the nuchal translucency. But a lot of times at the CRL of 45 millimeters, we may find that the nasal bone is not ossified. And unnecessarily, because we are doing an early scan, we may report it as an unossified or absent nasal bone, which will trigger off a battery of tests further, which may be really, really harmful. That is one. Another such marker is ductus venosus. It may be reversed at 11 weeks, but really normalized by 12. Thirdly, you cannot assess the structure of the fetus properly at 11 weeks as you can later. So at 11 weeks, these are the disadvantages. But at 13 weeks, the only advantage is that the structure is very beautifully delineated. Now, unfortunately, we call them as term NTs. We really hate to scan women when they come at 13 weeks and 5 days and at a CRL of 80 and 82 millimeters because they never pose for a good NT and an NB. So a kind of compromise between these two, optimally try to do the NT scans at 12 and 12 and a half weeks, which corresponds roughly to 60 to 65 millimeters of crown rump length, which is a good time to look at the nuchal translucency, the nasal bone, ductus, tricuspid, as well as the structures of the fetus. So this time would be good. And over the years, all the referring obstetricians, I have tuned them to adjust the dates even in cases of delayed conception, so that if there is a delayed conception, they don't end up coming to me at 12 weeks and eventually the CRL is only 40 millimeters. So they should look at the early scans and plan to do an NT scan optimally between 12 and 12 and a half.
Okay. Ma'am, Pratima ma'am, any comments about it?
I'm fine. I think 12-13 weeks is what I would prefer, and it's fine.
If patient comes at 45, 46 CRL, so shall we
You can do
complete
it.
the
It's not
scan that
about
time
doing
only,
it.
or shall?
No, you can do the NT scan. There is absolutely nothing wrong, and you cannot do it. And maybe if you do a transvaginal scan, you will see the heart and all those things also. It depends upon how good your visualization is. If your visualization is good, then I think the risk assessment is better at 11 weeks than it is at 12 weeks, right? So I will never send a patient away. If they come at 14 plus 2 days also, I will do the scan. I may not be able to do a risk assessment, but you can do all the other things. So, and advise them accordingly. So,
okay.
It's only for the risk assessment. To optimize risk assessment is what you need 25 to 84 millimeters. And for the anatomy, you see it more clearly from 55 millimeters onwards. So, that's what it is all about.
Pratima ma'am, can I ask you a question, ma'am?
Sure.
Ma'am, at a CRL of 45 millimeters, if everything else is fine and the nasal bone is absolutely not ossified, would you prefer calling her back in a week's time or 10 days rather than reporting it as unossified and kind of making her intermediate or sometimes high risk, those kind of situations?
Well, I think there are it's not like one fixed answer to this question, to be very honest, right? Especially in the era of NIPT, you cannot have one fixed answer, right? We know the risk assessment for NT screening is better at 45 millimeters, right? Your biochemistry is there, your thing. So it's only unossified. I will look at the NT. NT is looking normal. Your biochemistry is normal. So then, yes, whether the nasal bone gets ossified after 12, 13 weeks. But if it doesn't get, then you're again stuck at 12, 13 weeks. Should I repeat my NT scan at 12 weeks or should I go by the 11-week NT scan? So I don't know. So you have to have your focus clear. If you're saying I'm doing a screening, then I have to do complete screening at 45 millimeters. I cannot say I will do little bit, but I will not do that part. If I do it completely, and I will say, okay, fine, we'll have another look at the nasal bone. Now, whether you do invasive testing or not is the question, right? For the invasive testing, either you may choose in certain circumstances, the patient might be really hyper. You may say, okay, just do it and be done with it, because the risk of miscarriage is not so high anyway with the CVS if you know what you're doing. Versus you may have some patients say, hey, can we just wait for another couple of weeks and see. But remember, whether NT normalizes, your nasal bone comes back after 16 weeks, or your tricuspid regurgitation normalizes, or your ductus venosus normalizes, your Down syndrome does not change.
Does not
Baby
change.
has got Down
Very
syndrome.
true.
Even in Down syndrome babies, it can normalize. So
Yes.
this is, and if your aim is to detect the babies with Down syndrome, you're not there to sit and reassure every single patient that comes through the door, right? Certain times your clinical acumen has to, decide whether I should wait or whether I should, do something else right away, or in the waiting time, what else can I do? For me, here, NIPS is very useful because I tell them that if you're finding it difficult to wait and hang around, then do the NIPT if you want. And that's where, again, where the free amniocentesis, I will choose that lab which will give me free amniocentesis, because if this NIPT comes high risk, then or if that nasal bone is still absent at 16 weeks, then at least I can do an amnio if the patient wants. So this is actually, you have to individualize to each patient. It's like a tailor, you have to tailor, you have to cater it to that particular, one size will not fit everybody.
Yeah. Thank you, ma'am. Fortunately, in Pune, the distances are not as bad as Mumbai or Bangalore. And I find
distances are never bad. Distances are never bad. It's the will. It's the intent that is not there.
Comfortable to come back in a week's time when I am comfortable to report a normal report rather than scaring them away. But madam has given a very good take-home message. It's very common for obstetricians. Once we report the NT as 3.2 millimeters and suggest a further testing, they have an attitude of repeating the NT scan after 1 week. And like ma'am says, even if the NT normalizes, it does not take away the risk you had initially assigned to that lady. So do not send repeat NT scans to see if the nasal bone has appeared or if the NT has resolved, because these are all transient and dynamic markers. And the reason they've been allotted at that particular CRL, there is a reason. They were studied at that time and found to be the most effective. Thank you.
In fact, I will go one step further. In fact, when they come to me for second, third opinion for these kind of things, I actually go back and look at those images which have already been done. Right, and if those images are good and the blood has been done in a satisfactory way, I do not repeat risk assessment. I just go with what was given before, and we stick to those numbers. You don't keep changing the risks every time the patient walks in and out of the door. Right? You just, if it's not been done properly, then I said, okay, it's better that I have a look at the baby, and then we may want to repeat the bloods again, and then many of them will agree to do it. Some of them say, but I also tell them I can never remove the one, right? 1 out of 200 or 1 out of 2000, anybody can be the one. You have to decide whether you are comfortable being the 99 or you want to make sure that you're not the one. It's the attitude.
Yeah. Thank you, ma'am.
Well, Pooja, I will not ask questions to you now. I think you drive safely. Better.
Don't worry, it's on a loudspeaker, Sachin. I'm safe.
Next question I'll ask to Dr. Sita and Sucheta ma'am also. Very interesting scenario that in my practice, many invasive tests been done for FTS positive, but so far none has come abnormal. I have lost faith into this markers and NT scans. Please, Dr. Sita. Please correct me in my approach.
No, so as we said earlier that, invasive tests have done, we can't say that none has come abnormal. It's not so true. But again, it's important to know exactly when we're doing, for what indication we're doing the invasive tests and to follow them up properly. So if the NT was high and there are a few cases, even if they have not come abnormal as in for Down syndrome, there could be other problems in the baby which we should be looking for, like if the NT is high, looking for cardiac defects or other genetic abnormalities, so not limiting ourselves. So again, if you're just going to do a QFPCR or a FISH for karyotype, and then you're just looking for Downs and not looking for other things, so we don't know none has come abnormal. We don't know if they fall in the actual abnormal group or not. So that is what we need to look at, and that's what we are moving out of just karyotyping and going into chromosomal microarray and looking for other things. So it is important to note that is nothing a 0% or 100% in our in science anyway.
Okay. So Cheta ma'am, any comments?
Sachin, I will share an experience we had.
Okay.
So, one of the patients refused doing amniocentesis after a high risk.
Okay.
Of so many patients, one refused, and that baby turned out to be Down's later.
Downs. Oh my God.
That's fine. If the couple understands that and you've documented everything, it's the patient's choice. I mean, there's no harm. And some people, even after knowing Downs, they might continue the pregnancy. So it's not that the invasive test has to be done only for termination. It is also to be aware of what is going on and how well they are going to be prepared, both for the obstetrician and the couple. So somehow that is there, that if you're doing an invasive, it's only for termination. That should not be the intention behind an invasive test all the time.
And also, Sachin, with the more number of cases we see, we know which ones should opt for invasive. We keep talking about not testing, but we never study why she has come high risk. If she has come a high risk only bad bloods and everything on ultrasound looks fine, she is more likely to be, actually carrying a normal fetus. But if you suggest, so choosing which patients you are, choosing aptly which ones you are doing invasive will also decide your positive rate. So if you're doing invasive for only abnormal double markers and normal scans, they're mostly going to come out normal.
Okay.
And again, a very important thing is to be not try and be intimidating to the patient that all is wrong here. You start off on a positive note, reassure them that everything is going to be fine. We're just ruling out things, because the minute they hear, they go into a denial phase, then they will shop around for things. And by the time they come to you, it's already late. So that part of counseling also becomes very important, where you're more positive than negative.
Very true. I go to the next question. Again, an interesting
Sachin,
question. Yes.
One comment. The risk which you are getting is coming with the 5% false positives. So suppose you are doing an invasive and it doesn't come positive, that means it is falling in that category. And this attitude is just like that Indian attitude, na? Test bhi karaya aur kuch nikla bhi nahi. So that should not be there.
I just want to add in a simple point, if I can.
Yes, please.
Yeah.
Please.
So this, what is the definition of abnormal is something which I would want to say. Are we considering the outcome that the baby was abnormal or normal, or the test report which was abnormal or normal? Like, for example, if we've done an amnio and sent it for karyotyping, we found something on scan and we had a normal karyotype, it rather should alarm us, because we've seen something and we've not found anything on karyotype. There is a high possibility that there might be something more, like say microdeletion or duplication. So nowadays, that's why the shift from karyotyping to microarray. So that kind of definition, I think we should consider while we are taking this into account.
Now we'll come to the last concept, but some rapid fire questions I will follow to close the panel. This is a very important question. My patient is FTS positive, either only a double marker done or a NT double marker combined. But I want to do second trimester test. I don't want to go for invasive. I want to do quadruple marker. I want to do whatever genetic sonogram, whatever. How to explain this situation? And I asked this question to Madam only, Pratima ma'am.
I think this is certainly a choice, and that's a valid choice as well. Because some parents may not want to, in the first instance, go through invasive testing. So, in your second trimester screening, you remember you have the option of second trimester quadruple marker test with along with your genetic sonogram, and you have your NIPT along with your genetic sonogram, right? So because the NIPT can be done in the second trimester also. So if the NIPT, if they do NIPT along with your scan, then of course, because the accuracy of NIPT is so high, you can, it would be quite reassuring. Whereas if they go with a quadruple marker with the NIPT, again, anomaly scan, again, it's important to look through the checklist of all your markers. And there was a nice meta-analysis, I think somewhere in mid 2013-14 from Kipros's group again, which has given you the likelihood ratios for each of the markers and the absence of the markers. And of course, then you have to manually combine the first trimester combined test along with your quadruple marker test and your genetic sonogram as well. So you combine all that and you tell the couple whether you want to, whether the risk is going down or whether the risk will go up if you find any markers or if you're second trimester. So I think it's a valid option, and the parents do choose this option. And now because of the NIPT, things have become relatively easier. But I think there is still a role for second trimester, but you would consider your first trimester screening results only if your NT scan and your serum marker has been done correctly. If it has not been done properly, then I don't think you should consider that at all, irrespective whether it was screen positive or screen negative. You just go with the mother's a priori risk. Because at the end of the day, although you want to be very reassuring to the couple, you also need to put on paper the worst case scenario, because that's what people come to doctors for. If everything is going well, healthy, nice, everything is beautiful, hunky-dory, nobody wants a doctor. They want a doctor to find out if there is any problem in the baby. And that's actually patients fail to understand that. In fact, I tell parents that, look, you have come to me to find a problem in your baby, even in that 1% chance. You don't come to me for that 99% when everything is going absolutely fine. You don't need a doctor. You don't need a doctor to deliver you in the hospital. You can deliver in your house and everything will be well. But you come to the doctor just in case something doesn't go according to your plan. So I think there is a role, and we cannot negate that role.
Can I just add in here, saying that what Pratima said is absolutely true, in the sense that if the first trimester has been done properly, that when you do the second trimester, the a priori risk will change, in that you have to take that into account before you report the second trimester screening, rather than just. But if it's not done, I mean, if you're not happy with the report, then it's a different ball game. But if you're going to consider that, that will change the a priori risk, and you have to incorporate that when you're reporting the second trimester screening results.
Okay, we'll move ahead to some rapid questions. Some special comments also are welcome. Aspirin for all or only to the screen positive? Already madam has discussed about it, but why empirical aspirin not recommended? What is the reason, Dr. Sita?
Well, I think it's unnecessary giving any medicine to any, as it is, the patient has a lot of medicines to take. So if it is not indicated, you shouldn't be, and it does and can cause problems as well in terms of, acid, gastroesophageal reflux and stuff. And in fact, there was a study which showed that, if you if they did a survey among all the patients, and if they found that if it is not indicated, the patients really didn't want to take it. So if they think it was really going to it's going to be beneficial, which again goes from the clinician to tell them how it's going to be useful or not, which is our area of counseling there, they really don't want to take it. So I think it shouldn't be just be given because it's there, and I won't say it doesn't cause any harm at all. It does cause some harm, maybe not as much as the other medicines, but a drug not indicated is not needed.
But Pratima ma'am, as you said, you give empirically 150 milligram, you recommend, but I want to give only 75 as an empirical treatment. Am I right or wrong?
No, if she is screen positive for preeclampsia, I would give her 150 milligrams. Period. I mean,
But I
this
have
is
not
what I would
screened.
advise.
Okay.
Yeah.
Muj,
150 milligrams. If she is screen positive for preeclampsia, the risk is more than 1 in 100. 150 milligrams, that's the evidence, right? If she wants to take only half a tablet because somebody else, her grandmother or your mother-in-law told her, so that's the problem. My advice is 150 milligram, and that's documented.
A lot of these women who are IVF who actually come in with a 75 milligram already,
And
they are on it.
Yeah,
and then when you
we
do
did
the screen, you can increase it to 150. Yes, Pratima.
we did a small study, and we actually put up a poster in the World Congress as well, where we compared this kind of empirical 75 milligram, just give it to anybody and everybody, or people who are there on 75 milligram of aspirin versus people who are not taking, and then we compared the risk factors as well, and actually there was no difference. No difference. 75 milligram. See, the reason why IVF people give 75 milligrams is best known to them, right? If I want to reduce the risk of preeclampsia in this woman based on my first trimester screening, I have to give 150 milligrams. That's it. There is no debate about that.
True, very true. We are talking about
And there will
aspirin
never be a
reducing
debate
the
about
risk.
it, because this is proven beyond any comprehension, unless somebody brings up a study with recruiting many more women. That only Kipros has to do that again, I suppose. I don't think anybody has that bandwidth or the capability to now.
No, a valid point, very valid point put by Dr. Pratima is that here we are talking about reducing the risk of early preeclampsia for 150 milligrams. So, we are not debating about any other things which might be the cause of, as what the IVF people might need it. Yeah.
Now we come to some sonology part. Reporting of unilateral absent nasal bone. Is it absent nasal bone totally, or do we have to repeat after a week to see another nasal bone came or not? Dr. Priya.
Yeah, for the first trimester, we should stick to the nasal bone being present or absent instead of just measuring the nasal bone or saying unilateral absent. Although when we have a doubt, we can go and check it in the retronasal view, which I had shown that the apex is formed by the two nasal bones. And I think we should make a note. If we are very sure that one is present, the other is absent, we should make a note somewhere in our report and call her back at 16 weeks. And why this is so? Because there have been instances where nasal bone has been reported to be present, considering one was present. And then at 16 weeks, one was hypoplastic and the other was absent. And these are the scenarios when there is a lot of goof up, and then the previous person who has done the NT scan is blamed for that. So I think, yes, as ma'am had already told us before, this is again that gray zone question, which has multiple implications, but we should somewhere make a note. And if we are very sure of seeing the anatomy, seeing the retronasal triangle, seeing only one nasal bone at the apex, others not seen, somewhere we should make a note of that and then call her back at 16 weeks to assess, so that we don't get a blame for missing that absent, which will be missing at the 16 weeks, and the blame game is not happening.
Any comments?
Sachin,
Yes, ma'am.
should we not be writing not ossified rather than saying absent? Because the moment you say it is absent, patient go into a panic mode. What? The nose is not there. It is so flat. So I would rather prefer that if you write it is not optimally ossified rather than blatantly saying it's absent.
Yes, so true. We've changed our terminology, ma'am, for reporting. We've made it unossified, because yes,
Correct.
1 or 2 patients came back and they said, my baby doesn't have a bone, doesn't have a nose, forget about a nasal bone. So yes, so now we write it as unossified nasal bone, and which will be ossified later in gestation.
It's just that if your woman travels to UK and Kipros sees that report, right? Because it is still internationally, it is still absent nasal bone or hypoplastic nasal bone. Remember the terminologies. If you're talking about standardization, it has to be standardized everywhere, right? We cannot say in cross number 2, I'm going to call it unossified, but if I go to the next cross, it'll become, absent, or in the third cross, I'll start measuring it. So just be careful that this woman is not going to travel to England for Kipros to give a third opinion, or just share it on the email.
And the implications will
your
still be
FMF
the
number
same.
is there on your reports, remember?
Yeah, and Sachin, coming back to your first question, do we really need to standardize by FMF, or is it a fad? It's not a fad, and we've proven it. If you go back to the FMF, there are only 3 ways of reporting a nasal bone in 12 weeks. It's either absent, it's hypoplastic, or it's present. There is no unilateral, slightly, not slightly, maybe, not maybe. We have our FMF IDs, like ma'am said, yes.
And if you have a good image to prove it, you have it. That's it. And then it is your job to sit there and convince. I mean, why are we holding ourselves responsible for patients' personality? You know, we are not responsible for their anxiety. We are not responsible for their personality issues. Right? They are going to have far more anxiety problems after the kids come out. Right? They're going to have far more problems then. We should not be responsible for that. We have to tell them what is there, put it on the table and explain it to them. Maybe spend an extra 10-15 minutes with them. Once you step out of that room, you forget about that patient, switch on for the next patient. That's it. Let us not hold ourselves responsible for what problems, psychological problems the mothers are having.
And whatever you
adding
write,
to what
the
Priya said,
implication.
she's actually right, because most of the women feel that their baby does not have a nose. But a simple statement explaining to the
That's
couple,
world
like
over. That's
just
world
tell
over.
them,
It's
and
the
that's
same
the end of the
story.
story. Yeah.
The mothers are same everywhere in the world, and these pregnant, anxious mothers who are like gone psychologically mad with markers are the same everywhere. They are no different, right? Yes, we should reduce their anxiety. We should, attend to them, but we are not responsible for that. We can help them to an extent, right?
Come to the last question. Since Pink Puja is back, it's cystic hygroma in first trimester. Directly terminate, or shall we go for invasive testing?
So explain to the patient, there are chances that this fetus could be normal, but the chances are just 10%, quoting Fetal Medicine Foundation. 90% of the times, either the microarray is abnormal, so there is a chromosomal abnormality, or there is a structural abnormality. And even if the microarray and the structures are normal today, you don't know what will evolve tomorrow with increasing gestation. Even fetal losses of an apparently chromosomally and structurally normal fetus with cystic hygroma are known. So before you commit to the patient about rocket science values and giving them lots of hope कि नहीं कुछ नहीं होता, आगे जाके resolve हो जाएगा. Cystic hygroma may resolve at 16 weeks, doesn't mean that her risk for a chromosomal abnormality or a structural defect has gone down. So you have to give these statistics, and most patients of cystic hygroma will then go and not continue the pregnancy, which is a fair enough option. Some of those who do, we have to be at guard. So we have to subject them to all those list of investigations. And yet, like we all do on our reports, right, the last line, evolving anomalies may be seen with increasing gestation and even postnatally. So that's how.
Anu ma'am, any comments? Anu madam and Rahul sir, and then we'll stop.
No, I agree with what Pooja has said. But then at the back of my mind as an obstetrician, that turners will always be there.
Yeah. So we'll do a microarray, ma'am. Yeah.
Yeah.
50% of these will be turners, ma'am.
Yes.
Rahul sir, any comments? Last comments?
Sachin, you asked for my opinion. I will go by your opinion.
Good one.
So we stop here. It was a wonderful panel. And thank you, our teachers. Thank you, seniors and fellow panelists. Thank you, Anu ma'am and Rahul sir. I think the audience has got the message what they wanted. Thank you.
Thank you very much. And thanks. Nice seeing you, Anu. Nice seeing you, Sita.
Yeah, same
Bye.
here.
Bye, ma'am. Bye, ma'am.
Thank you so much.
Bye.
It was a pleasure being here. I really enjoyed. I
After
always
a long
enjoy
time.
a lot with Navi Mumbai Society, I must say.
We all are missing you.
So am I. It's
At
been
the
a
end of
really
the
long
session-
association. I just love
Yes.
your society.
At the end
You're
of
so
the session,
friendly.
I take
Bunch
this
of
opportunity to thank all the faculty who have taken out their time and joined us for this wonderful program. It has opened up a lot of queries and answers to it. Thank you. Thank you.
I must say, all the faculty, Sita, Pooja, Priya, Sachin, they all did so well. Well done. I'm so proud.
Thank you so much, ma'am.
Thank you so much, ma'am.
Thank
It's
you so
always a
much.
pleasure to have you in our society.
Yes.
Wish we have you in person.
It won't
By
be long.
default,
now.
I'm there many times, which is nice.
Yeah.
Thank you.
Thank
Thanks
you.
so much.
Bye-bye. Have a good
Have a
day.
nice Sunday.
Bye. Have a good day.
Bye.
Bye.
Such excellent attendance in this pandemic of webinars also. That's also a huge achievement.
I know still 73. I mean,
Yeah.
they are waiting for the
Well, it went
panel.
up to 185. I mean,
Yeah.
now the city
Attendance
leaving,
was close to 200, 185.
Yeah, it was very good.
Sucheta ma'am,
Thank
we
you,
asked
Rahul
some
sir, for the
questions for you
opportunity.
also, but you were not there.
हाँ सचिन
Mute ma'am.
Madam,
You're on
तुम
mute. Ma'am
Madam-
तुम्हें mute है हाँ.
No. I said I went for lunch in between with the assurance that this panel will be available on tomorrow.
Okay. Good day. Good day, Pooja.
Bye. Thank you.
Bye.
Thank you, Sachin. Thank you,
Bye,
Rahul
everyone.
sir. Bye,
Bye,
Priya.
Priya.
Bye
Thank you,
Pooja.
ma'am.
Thank you.
Bye.